to today's opioid overdose prevention for hospitals. My name is Joe Manny. I will be your producer for today's event, which means that before we get started, I want to take us through a couple of housekeeping steps. First, I want to let you know that live captioning is available today. You can click the link on your screen here, or if you look down below the slide, you'll see it in the All Questions box. It is the very top link here, and you can click that one, and that will take you to the captions, open them up on a different screen at any point during today's event. You'll be able to adjust all sorts of things about the captions there, and if you have any questions, do let us know in that All Questions box, and we'll be happy to help you out. Quick note about audio today. Audio will be broadcast through your computer speakers, and your lines will be muted through the duration of the event. So that means that if you can hear me coming through your phone and your computer, you are welcome to hang up your telephone. It's whatever you prefer. And if you need any help at all, do let us know in that All Questions box. Up at the very top of the meeting room here, we have a toolbar, and it has the meeting tab on it. There's an audio setup wizard. So just like what you see on the screen here, you can click that audio setup wizard. It'll take you through a few steps that will help you get your computer speakers or your headset dialed in. And there's also a speaker icon where you'll be able to adjust speaker volume in the room or select a different input. So if you plug some headphones in and you're hearing it through your computer speakers, you can find that option under the speaker icon to select different speakers. And of course, if you have any questions at all, let us know in the All Questions box. That is below the slides. And all you need to do is type into that bar on the bottom and then click the little chat bubble there, and we'll be happy to help you with any issues that you might have. If you hear an echo, if the slides aren't refreshing for you, anything like that, let us know. We have lots of solutions for you. Also on the screen, you see another way to communicate with us. That is through the public chat. I see lots of folks chiming in, letting us know where they are joining from. Much appreciated. That's your space today, so if you want to network with your colleagues, if you think there's a resource that would be appropriate to share, please do let us know in that public chat. We just want to let you know that this is being recorded, so anything that you put into that chat will also be in the recording. So I would like to remind people to always be kind. If you can't hear audio or anything like that, you probably can't hear me say this, but do put all your questions in the All Questions box, and we will be there to help you out. One last note here, and that is in the lower left corner of the slide, you will see the 4 outward-facing arrows. Those 4 arrows appear on the toolbar up at the top of the slides. You can click those at any point to go full screen, make your slides full screen. So I do encourage you to use that. And if you want to download the materials today, just click on any of the materials in the lower left corner and choose Download File, and that will download those materials. So as I said, let us know in the All Questions box if you have any content or tech questions. We'll be here to help you out, and we'll make sure all of your content questions get over to our speakers today. Put them in the public chat. We might not see them as quickly or as easily, so please do use that All Questions box. And now I would like to ask David Jones to join me up on screen and unmute. Director Jones?
Thank you, Joe, and welcome again, everyone, to the presentation on opioid overdose prevention for hospitals. I would like to begin by certainly thanking all hospital personnel for their tremendous service during this pandemic. The amount of commitment and sacrifice has been nothing short of miraculous. Illinois Department of Human Services Division of Substance Use Prevention and Recovery wants to explicitly express our gratitude for the kindness and selflessness demonstrated during these unprecedented times. And as we all know, the opioid epidemic has continued to ravage communities in addition to the pandemic. However, it's important to know, particularly in the face of these catastrophic circumstances, that we're utilizing strategies that abate harm and, moreover, strategies that have substantial evidence to show effectiveness in helping people experiencing the disease of addiction to find a pathway that leads to long-term sustained recovery. There's a preponderance of evidence demonstrating medication-assisted recovery is effective in treating opioid use disorder. We know that hospital settings and emergency departments specifically provide an opportunity for two strategies that have proven to be effective. One is warm handoff, and that is partnering with people with lived experience to assist in connecting with recovery support, including educating about naloxone and the social determinants of health, inclusive of resources around housing, employment, financial literacy, and of course, connecting to the behavioral health treatment network. A second strategy, initiation on medications to address opioid use disorders such as buprenorphine, can be a life-saving intervention, and hospital emergency departments are uniquely situated to provide this real-time strategy. When a patient makes a decision to participate in taking, whether it be methadone, buprenorphine, Vivitrol, along with participating in a cognitive-based therapy, hospitals provide an opportunity for continuity of care that can result in effective health outcomes. Hospitals are a vital touch point for reaching people with a substance use disorder and others at high risk of overdose death. We encourage, that is, as the Department of Human Services, Substance Use Prevention and Recovery, the investment in the hub and spoke model in which hospitals can serve as the hub and connect people with substance use disorder to community-based mental health and substance use providers. If we pause for a moment and look back, we know that prescription opioids were the impetus to the current opioid epidemic. However, we know the greatest contributor to overdose deaths are illicit opioids, primarily heroin and fentanyl. And we know more and more that fentanyl is being laced in other drugs and chemicals. We also know that people can be polysubstance users, and while we're focused on combating the opioid epidemic, we must keep an eye towards the future and use surveillance data along with predictive analytics to forecast the role that stimulants like methamphetamine, or for that matter benzodiazepines, are playing, and push out strategies that mitigate the effects of other drugs and substances. And we have to continue to implement interventions like safe prescribing practices, along with exploring alternatives to medication. Fortunately, our state has a continuum of prevention, harm reduction, treatment, and recovery services available. Throughout this morning, you will hear from Drs. Kim and Nelson. They will share insights about how partnering with hospitals and emergency departments can prevent opioid overdoses, and how implementing harm reduction strategies, along with creating linkages to community resources, can result in better health outcomes. Again, the Illinois Department of Human Services Division of Substance Use Prevention and Recovery are proud to support today's event, and our sponsorship is an acknowledgement of your vital role in reducing harm in the lives of people who suffer from the disease of addiction. Thank you, and stay tuned for a wonderful event. With that said, I'm going to pass it over to Dr. Kim.
All right, thanks, David. Can everybody hear me okay?
We can hear you, but we can't see you yet. You might need to click Start Sharing on your video preview. You are. Thank you.
There we go. Sorry about that. Standard web conferencing hiccups. So you can see me okay and you can hear me okay, I assume now. Greetings, everybody. My name is Howard Kim. I am an emergency medicine physician at Northwestern Memorial Hospital in downtown Chicago. I'm happy to be here today to talk to you about building a naloxone distribution program from a hospital or emergency department setting. Because I am an emergency department physician, I sort of have a natural tendency to use the term, building this program from the ED setting, but I just want to reassure you that all the things that I talk about today can be accomplished from the emergency department setting, And they can also be accomplished from the inpatient hospital setting. So if a patient's admitted to the hospital for a couple days, the same sort of principle applies, distributing naloxone from the hospital setting, even though I may say it from an ED perspective. I'm sorry, I'm just used to saying ER and ED. I do want to say that I've attached a link at the bottom of this slide here, this little bit.ly link. It's a personal Dropbox folder that you can click on and download all of the references for my talk. So you don't have to feel the need to take copious notes or screenshot anything. All of these references, even the slides, will be available at this link, and I'll post a link again at the end of the talk. So I spend about half my time working clinically in the emergency department and half my time doing research. So I have some relevant grant funding that I need to disclose. None of it has a conflict with the contents of today's talk, but we have some funding from the Agency for Healthcare Research and Quality. We have an ongoing project evaluating physical therapy initiated in the ED for low back pain and whether physical therapy in the emergency department can reduce our reliance on opioids for this very common problem. We also have some funding from the National Institute of Drug Abuse. We are participating in a 30-site national trial that's investigating extended-release buprenorphine injections in the emergency department for opioid withdrawal. It's an investigational drug. It's a 1-week injection instead of the standard sort of 1-month injection. And we're hoping that it'll help us overcome some of the barriers that are associated with filling a traditional buprenorphine prescription and filling it from the ED. And so that trial is just recently launched, and so hopefully we'll have some results to share with you about a year from now. I am also an assistant editor at JAMA Network Open, and I get an annual stipend for that. But overall, the contents of this talk don't reflect the views of my employer at Northwestern or NIH, HRQ, or JAMA. I also want to give you a little bit about my background and my interest in this topic. So even though I am a researcher, my interest in harm reduction for opioid use disorder doesn't stem out of my research interest. It stems out of a sense of clinical inadequacy and failure I had about 4 or 5 years ago. I remember there was a particular pivotal moment when I was working in the ER, and a patient came in with a chief complaint of, I need help for my opioid dependence. And he told a pretty classic story of, I started out with, say, a lower back injury. I started taking prescription opioids to manage the pain. Eventually that progressed to heroin use, and now I've been using heroin every day for the last several years. And he came to me in the emergency room and he said, I'm here for help. I need your help. Heroin is destroying my life. It destroyed my marriage. It destroyed my family. I got fired from my job. It's destroying everything, and I need your help. And I did what I was trained to do in residency, which is I went to our internal website. I clicked on the little link that has our document with all the outpatient clinic numbers, the rehabilitation centers, the quote-unquote detox centers that we could refer patients to, and I printed out the list and I handed it to him and said, here you go, this is all the information we have. And I distinctly remember sort of the look he gave me, and he said, that's it? I can't believe this is all you have to give me. What am I supposed to do with this? Giving me a phone number on the weekend or a list of phone numbers isn't the real help that I need. And, that was a really pivotal moment for me in my career because I realized how inadequate our care for opioid use disorder is. We have all these fancy and advanced clinical care pathways, all this evidence for people that present to our emergency room with chest pain, with stroke-like symptoms. We can rapidly arrange an outpatient stress test. We can stratify their risk of having acute coronary syndrome. We can stratify their stroke risk. We can rapidly start them on medications. But we had nothing for opioid use disorder. That was a really pivotal moment for me in my career. And since then, over the last 4 or 5 years, I've worked to build our take-home naloxone program at Northwestern and also our ED-initiated buprenorphine program. So really, the background for this talk lies in my experience building our take-home naloxone program at Northwestern and talking to a lot of my colleagues in the Chicago area about how they built their programs, and I hope to share those with you. I'm just looking at the public chat right now, and I see that there's a lot of people from different settings here, including different hospitals as well as outpatient treatment centers, and it looks like even some companies maybe that distribute naloxone. So I'm hopeful that I can learn as much from the audience here as you're able to learn from this talk. So before we begin with the content of the talk, I want to ask a very simple rhetorical question to establish some premises. I realize that I'm preaching to the choir a little bit because you wouldn't be attending this talk if you didn't already believe in distributing naloxone, and you don't need me to convince you that it's necessary to do. So I think it's important to establish some basic premises that we'll use later in the talk. We distribute naloxone to save lives. It's really as simple as that. So our patients are in the water, they can't swim, and their arms are flailing, and they're drowning. And a naloxone literally saves their lives. We're throwing a life ring into the water so they can hold on to and not drown. It literally saves their lives because we know naloxone rapidly reduces the clinical effects of opioid overdose. But also it symbolically saves their lives because it gives them sort of like a backup. So the next time they use, they won't experience an overdose, or they won't experience respiratory depression and die, that they'll have sort of a tool to use. So that's the first premise, that really we should just view take-home naloxone as a very simple tool. We're just using it to save lives. And the point I always try to make is we need a person to be alive in order to meaningfully engage them in treatment. So while buprenorphine medications for opioid use disorder is vitally important to these patients, first we have to make sure that we can keep them alive in order to connect them to that treatment. The second reason we distribute naloxone is because it means something to the patient. It is a token that increases the therapeutic alliance between the clinical care team and the patient. I don't think that we appreciate enough how miserable of an experience it is for patients to come to the emergency department to be hospitalized in the hospital for an opioid overdose or an opioid-related complaint. I think all too often these patients are treated with a lack of dignity. They're sometimes treated as subhuman. We sort of put them in hallways, hallway stretchers in the ED, and just wait for them to quote-unquote sober up. And then when it's time for them to go, we usually include like some sort of pedantic or not helpful discharge advice like, stop using heroin. It is bad for you and it will kill you. And that advice is not helpful. The way we speak to these patients is dehumanizing at times. And I think universally, they don't want to be in the emergency department. They don't want to be in the hospital, and it's a bad experience for them. I think that giving patients take-home naloxone or distributing naloxone is sort of the first step in changing that narrative. It tells the patient that I'm here to help you, I want to help you, and more importantly, it tells the patient that I respect your autonomy. I respect the choices that you make in life. I'm not here to judge you. You know, all too often we talk about drug use in terms of a moralistic failing, when really in the healthcare setting we need to talk about it in terms of being a medical problem. And it begins to signify that. It begins to say, I want to keep you alive. You matter to me. And you know, when you're ready to have the conversation about engaging in treatment, I'll be here for you. And you know, we're really here to make sure that you can be the best version of you that you want to be. The third reason why we distribute naloxone is that it opens up a door for a conversation on medications for opioid use disorder like buprenorphine, principally in the emergency department. I think, like I was saying before, visiting the ED or the hospital is a universally bad experience for these patients, and it's time to change the narrative. I don't think it's possible for us to change the narrative just with one ED visit or just with one simple gesture, but I think we start to chip away sort of at the rough exterior of bad experiences that these patients have had in the past. And once we start to change their perception that the emergency department or the hospital is a safe space for them, that they're actually welcomed there, I think that's, you know, we plant the seed for that patient eventually coming back to the emergency department when they're ready to engage in treatment for their opioid use disorder. And I think that take-home naloxone is sort of vital in setting up that subsequent endeavor for success. I'm showing this graphic here because I want to say that naloxone and medications for opioid use disorder like buprenorphine go hand in hand. You can't have one without the other. So going back to that analogy, take-home naloxone is literally a life ring. The patient is drowning in the water. We throw it out to them so that they don't drown. But then after we throw them the life ring, they're still stuck out there in the water. It doesn't get them home, doesn't get them out of the water. I think in order to successfully bring these patients home, we need to engage them in further treatments like buprenorphine. My colleague Mike will be talking about that next after this talk, so I won't, I won't spoil his talk talk too much more about buprenorphine beyond setting that up initially. So I have some simple objectives for today's talk. The first is to describe recent trends in Illinois opioid overdoses. The second is to define various models of naloxone distribution. Then we'll discuss some common barriers to implementing a naloxone distribution program, and I'll talk to you about some different ways to overcome those common barriers. And then finally, we'll describe some key logistical details for you to build and sustain your own naloxone distribution program. So beginning first with describing recent trends in overdoses. So probably for 10 plus years, we saw a steadily increasing number of opioid overdose deaths. It was really disheartening, but around 2018 to 2019, opioid overdose deaths, both in Illinois and nationally, started to plateau and maybe even decline a little bit in 2019. So we got a lot of encouragement that maybe some of the initiatives we were undertaking were working. However, the most recent data from early 2020, the first half of 2020, have not been reassuring. So this is data from the National Vital Statistics System. It's provisional drug overdose death counts from the CDC. The y-axis is the 12-month rolling average of drug overdose deaths for opioids in Illinois. So that number of 2,500 in June 2020, that's over the last 12 months. And when we look at the national data, the United States data, we see a very similar trend. So this is the Illinois data and the national data. Again, we had a steadily increasing number of opioid overdose deaths over about 10 plus years. Things looked like they were starting to plateau in 2018, 2019, and then again we saw an abrupt uptick in early 2020. If we try to slice the data in another way, it tells the same story. So this is a different outcome we're looking at now in Illinois. This is the number of ED opioid overdose visits. So this data is gathered by IDPH. It essentially looks at ICD-10 codes for opioid overdose in Illinois EDs. So while the prior outcome looked at the number of opioid overdose deaths, which could occur in the community or in the hospital, this looks purely at ED visits for opioid overdose. And here we see a clear trend, a steady increasing trend from 2013 to 2020, and the number is still going up. If we look at the data in a third different way, this is the number of EMS encounters. So these are basically ambulance calls in which the paramedics in the field delivered naloxone. We see a similar trend to the opioid overdose data. So it looked like things started to plateau in 2018 and 2019, finally started to decline, and then in 2020, again, we see an abrupt uptick of the number of EMS encounters in which they delivered naloxone. So really, any way we look at the data, it's clear that there's a trend in 2020 that we're having increased opioid overdose deaths. This is data from Chicago, from the Chicago Department of Public Health, and it basically shows what I'm guessing you're seeing in your own communities as well, is that the vast majority of overdose deaths involve fentanyl, probably 80%. That hasn't changed in recent years. In January to June of 2019, 80% of opioid overdoses involve fentanyl. In January to June of 2020, 82.2%. And really that's the trend that we've been seeing over the last few years. So sort of the overarching question that everybody's probably asking is all this due to COVID? This is a recent study published in JAMA Psychiatry. The data here is basically overlaying graphs of overdose-related cardiac arrest for 2018, 2019, and 2020. And 2020 is in the blue here. The dashed vertical line you see between March and April is right around when WHO declared COVID-19 as a pandemic. And the pattern that we see is pretty clear. There's a large increase in the number of overdose-related cardiac arrests in the national population. So this is from National Emergency Medical Services calls. I think that there could be a couple reasons that COVID has really contributed to a worsening opioid overdose trend. I think one, obviously there's been a huge disruption in outpatient services for opioid use disorder, where people, traditionally or had stable outpatient providers for their buprenorphine or methadone that got disrupted initially when COVID came about. I know anecdotally at Northwestern we had an increasing number of patients who came in saying they couldn't access their typical buprenorphine prescription and needed sort of a bridge prescription from us, or they needed a dose from us. I think the second reason that COVID could be impacting this is really just broadly in the general public. We're seeing increasing levels of depression and anxiety and stress, which is understandable given all that's going on, and even increasing amounts of substance use, so people using more alcohol at home, et cetera. So that could be another reason. I think a third reason is there's been a lot of economic harm as well. There's been a lot of jobs lost, income's really gone down, and anytime, of course, you see economic struggle, you see opioid overdoses go up as well. I think I'm not really here to try to convince you that COVID is the reason that opioid overdoses are going up. I think that it's an interesting debate that a whole different talk could be devoted to, but I think the important fact is that the trend of early 2020 is pretty clear, and whatever the reason for us seeing such a large increase in opioid overdose, we really need to do something about it. And sort of as David talked about in his introduction, we think that two most effective tools we can have from the emergency department and hospital setting is to distribute take-home naloxone and to initiate patients on buprenorphine. The second objective for today is to define some various models of naloxone distribution. And I want to begin with some very simple definitions of prescribing and dispensing to build the foundation for this talk. So prescribing, we all know what this is. This is a very indirect means of getting naloxone into patients' hands. This is the traditional process of a patient writing a prescription, or in fact, now there's a naloxone standing order, so a patient could use the naloxone standing order as their prescription, and then filling it at a pharmacy. So that means taking the prescription to a pharmacy, dropping it off, waiting, the hour or two for the pharmacy to fill it, then giving the pharmacy your drug prescription coverage, paying the copay, and going home and remembering to going home and taking it. And that's the very sort of traditional prescribing method that we know, but has a lot of steps. Unfortunately, we know that this method of distributing naloxone isn't very effective. So a recent study out of the Cook County ED found that less than 1 in 5 ED naloxone prescriptions were filled. And this is at Cook County Stroger Hospital, where the retail pharmacy is located in the same building as the ED. It's located down the hall. So there's not a lot of geographic barriers in the way of patients actually filling their naloxone prescriptions, yet less than 1 in 5 ED naloxone prescriptions were filled. And really, this shouldn't surprise us at all. We know that there are multiple barriers to prescription filling. Even for somebody like myself who knows the healthcare system well, I work at a hospital that has a retail pharmacy. I routinely have prescriptions waiting for me at the pharmacy. In fact, I do now that have been waiting there for over a week because you have to figure out transportation. They're not always open. It doesn't always work out with your work schedule or your family obligations. And it's not easy, even for somebody of means with good access to the healthcare system and good knowledge to the healthcare system. On top of that, there was a recent study published in JAMA Network Open in which researchers in Pennsylvania acted like secret shoppers. They called around anonymously to different hospitals in Pennsylvania and asked about the availability of Narcan nasal spray. So this was after the advent of a naloxone standing order in Pennsylvania, where anybody should be able to get a prescription without a doctor's visit or without a doctor writing that prescription. Those researchers found that a third of the pharmacies they called reported that they did not have Narcan nasal spray in stock. So right off the bat, 1/3 of pharmacies said, "I'm sorry, we don't have it." On top of that, 2/3 of pharmacies reported that they weren't aware of the naloxone standing order. So they either said, I don't know what you're talking about with a standing order, or they misunderstood it and said, oh yes, even with the standing order, we still require a doctor's prescription in order for you to get the naloxone. And so, on top of sort of the general problems with prescription filling for any medication, it's even harder for naloxone. Finally, the researchers asked, well, what is the cost of the Narcan nasal spray if I just buy it without insurance? And they found the median cost was $145, which for nearly all of our patients will be an insurmountable financial barrier. Finally, there's a huge amount of stigma that's associated with filling a naloxone prescription as well. If you remember, when a patient fills a naloxone prescription, someone has to educate them on how to use the naloxone. You can just imagine standing in line at Walgreens, all the people are standing behind you, and the pharmacist is teaching you how to use naloxone. Okay, if you experience an overdose or someone around you has experienced an overdose, you'll see the respiratory pattern go down, they'll turn blue, and then you're going to inject this medication. It's not very discreet at all, so there's a lot of stigma associated with it as well. On the other hand, dispensing is the process of handing the medication to the patient. So that's what the pharmacy does. When they've completed all those steps, they dispense the medication to the patient to go home with. We can also do that directly from the hospital or ED settings. And in this context, this means handing the medication to the patient as soon as they walk out the door. This is what I mean by take-home naloxone. This removes all of the multiple barriers that we talked about in the prior slide. It removes them all from the equation. We don't have to worry about limited open hours, right? A patient leaves the ED at 3 in the morning. Of course, the pharmacy isn't open. That's what take-home naloxone accomplishes. We don't have to worry about the patient getting transportation to the retail pharmacy. We don't have to worry about the stigma of going to a pharmacy and getting a naloxone prescription and being educated on how to use it. We don't have to worry about limited stock or the cost. We sort of take care of that all up front so the patient has no barriers to using naloxone. So literally, when they walk out the door, they have it in hand and they can use it immediately if needed. And I think for all of us that work in the clinical setting, we know that it's not uncommon for a patient to leave the ED or hospital and to use heroin again immediately, sort of in the next hour or so. So it's vitally important that we put this immediately in their hand. The picture that I'm showing here is the typical take-home naloxone kit we give out at our downtown hospital. It typically comes in a Ziploc baggie, but I've removed the contents here. There are 3 vials of 0.4 milligram naloxone. There's 3 individually wrapped sterile single-use syringe and needles attached. And then we have a little insert that tells them how to recognize overdose, how to administer the naloxone and draw it up, and where to go if they want to seek further resources or help. And we also teach them how to use that in the ED. Finally, I want to talk about a model called facilitated outpatient filling. And this is sort of a hybrid of the prescribing and dispensing models that's primarily used for hospitalized patients. That's the only time I've seen people take up this model. And it's kind of, it's not a new method of distribution, I would say, but it's more accomplishing the steps of filling a prescription on the patient's behalf. So the inpatient care team assists in fulfilling all steps of obtaining the prescription medication on behalf of the patient. So say a patient is admitted to the hospital for a skin and soft tissue infection related to their opioid use, and the team wants to get them a take-home naloxone kit to go home with because they have high-risk opioid use habits. Basically what will happen is a prescriber on the team writes a prescription for naloxone, then they transmit it to the pharmacy on site. So there has to be a retail pharmacy on site. They transmit it by either faxing or calling or electronically. Then they wait for the pharmacy to fill it, just like a traditional prescription. And then either the inpatient team sends a courier over to pick it up, like a medical assistant, a nurse, social worker, any of the above, or the pharmacist sends over like a pharmacy tech courier to drop it off. And then the take-home naloxone kit, i.e. the filled prescription, is kept with the patient's belongings and given to the patient at the time of discharge, along with their discharge instructions, and they teach the patient how to use it. And I'm sure you can see just from my description of the process that there's a lot of disadvantages. It requires a substantial time investment. That's why it can only really be accomplished in hospitalized patients, because you have to wait for the prescription to be filled. You're basically doing all the steps of filling the prescription on the patient's behalf. And it often requires processing of patient insurance or payment. So, this goes through the typical process of filling a prescription in which they ask you for your prescription coverage and tell you, this is the copayment. And so what do we do about patients that aren't insured? Because we know that it's a large bulk of our population as well. I will say I know of one emergency department that's tried this sort of facilitated outpatient filling model and wasn't able to implement it successfully. It just took way too much time. The ED is a very busy place. The emergency medicine physician is tasked with handling a growing number of patients simultaneously, and it's just too difficult for the ED staff to accomplish all this on behalf of the patient, especially when patients are only in the ED for 2 or 3 hours, and there's no cap on the number of patients that we can receive. So I've only seen this accomplished in hospitalized patients. But I think I would really say out of these 3 methods, the indirect prescribing, the direct dispensing, the facilitated outpatient filling, really the gold standard is direct dispensing to patients, the model I talked about before of take-home naloxone. This is what we're hoping to achieve. This is the gold standard. This is what's going to help patients the most, and this is what we should all be striving towards. In programs that have facilitated outpatient filling models, for the most part, my experience with them has been that they tried a direct dispensing model and weren't able to accomplish it, and so they thought this facilitated outpatient filling was sort of the next best thing, which I totally agree is the next best thing. But if you're attending this talk, the purpose of this talk is trying to figure out a way to get this direct dispensing model to work. Now, there are a couple different formulations that naloxone can come in. It can be delivered intramuscularly. It can also be delivered intranasally, and there are some different formulations for each of those delivery types. The first formulation for the intramuscular version is a vials and supplies kit, so this is my terminology, but it's essentially what I described before. It's a little Ziploc bag, sort of a do-it-yourself kit of all the supplies you'll need in order to administer naloxone. They typically contain 2 to 3 vials of naloxone, as well as 2 to 3 single-use sterile syringes and needles, and then some other materials that the patient may need as well, like alcohol swabs or like the little handout that goes over the education with them. There's also a proprietary technology called Evzio. This is, as you can see, it's basically the Tesla of naloxone delivery devices. There's a audio speaker, there's flashing LED lights, there's viewing windows to see what's going on, there's safety guards, there's a base. It's a very advanced technology, and as you can imagine, it also comes with a heavy price tag. So this is sort of similar to EpiPen proprietary technologies. It's going to be more expensive because of all the patenting that comes with this proprietary technology. In terms of nasal distribution, all of you are probably most familiar with Narcan nasal spray. This is a single-step nasal spray that's probably the easiest for patients to use. As you can see, it's ergonomic. You just put your 2 fingers on the top part and your thumb on the injection button, and then you place the nozzle in the overdose patient's nose and spray the material into their nose. Another type of nasal delivery is a multi-step atomizer. This requires a couple steps. In the box, there's a vial of naloxone and a syringe for delivering the naloxone, and then programs have to supply their own mucosal atomizer devices. So that's the little pyramid or the funnel-shaped tip on the right. You have to screw onto the end of the syringe, and that basically converts or atomizes the liquid solution into a nasal spray that can be delivered to the patient. So the tip of the funnel goes directly in the patient's nose. I would say out of these 4 formulations, the 2 most common things, or 2 most common versions I see are the vials and supplies kit and the Narcan nasal spray. And then I've seen a small minority of programs use the multi-step atomizer kit as well. Now, naloxone can also be distributed from multiple settings. The 3 main settings are community-based distribution, jail-based distribution, and hospital and ED-based. For community-based programs, what these typically look like are nonprofit organizations or departments of public health that distribute naloxone to either actively using persons in the community or bystanders in the community who want to be equipped to administer naloxone if they encounter an overdose. But Chicago Recovery Alliance is a good example of one, a community-based effort. They basically have a number of vans that travel throughout the city. They're in different locations every day that are posted publicly, and they offer a number of services such as clean needles, as well as opioid overdose education and naloxone distribution. Another example is the DuPage County Department of Public Health, who offers curbside pickup of take-home naloxone for their community members. You can make an appointment off their website. So these are just some of the many examples of community-based distribution. There's also a growing trend of distributing naloxone from the jail setting. So jails from Chicago, New York, Philadelphia, San Francisco, LA are all implementing jail-based programs now. And really the rationale behind this is people released from jails who are opioid users are at very high risk for overdose because during the time that they're in jail, they're not using the typical amount of heroin that they use every day, or they're not using any amount, in fact. So their tolerance goes down. But when they're released from jail, they go out and use the same amount of heroin that they typically use, but now their body isn't tolerant of the effects anymore. So whereas they could previously tolerate a certain amount of heroin without overdosing, now they use the same amount after being in jail for a while and they overdose. And really these programs have been very successful. We'll get into the data in a little bit. And finally is hospital and ED-based programs, which we're talking about here right now, and I assume is why most of you are attending this talk because of your interest in that. But I would say no matter the setting, naloxone distribution works. So whether it's community-based or jail-based or hospital ED-based, naloxone distribution works. And we have a large number of studies that have demonstrated that to us. So in Massachusetts, they implemented a number of early opioid overdose education and naloxone distribution programs. Sorry, I didn't define this acronym before. OEND is Opioid Overdose Education and Naloxone Distribution Programs. They trained about 3,000 bystanders in Massachusetts communities and reported over 300 community rescues. So that's a utilization rate of 11%. And they found a reduction in overdose deaths in communities that had high enrollment in these programs of almost half. That 95% confidence interval is a typo, but if you go to the slides that I've posted on the Dropbox link, again, I'll post that link at the end of the talk again. You can download a current version of the slides. A outpatient opioid treatment program in New Mexico, so this is patients actively engaged in treatment, gave take-home naloxone kits to all patients. They trained nearly 400 of their patients who came back and reported over 100 community reversals. That's near 18%. The San Francisco County Jail program trained 453 inmates and who came back and reported 63 community reversals. That's almost a 14% utilization rate. And then right here in Cook County, Cermak Health Services reported that they trained 60 individuals who reported 23 community overdoses. So again, that's around a 38% utilization rate. So, the data are very clear. This is just some back of the envelope math of the pooled utilization rate from all those studies. A 14% utilization rate, that's 1 in 7. I would say that there's not a lot of things in medicine that we provide to patients that they take home with them that has a number needed to treat of 7. That's certainly not the number needed to treat for sending somebody home with a statin or an asthma inhaler. A number needed to treat of 14% in order to save someone's life, or a number needed to treat of 7 in order to save someone's life is astonishing. This is clearly an effective intervention, right? If for those that work clinically, you see that naloxone literally reverses opioid overdose immediately. It's like raising Lazarus from the dead. And, a 14% success rate is amazing. And it really speaks to why we should be doing this for everybody and why we should really dedicate our efforts to getting it into people's hands immediately as they walk out the door. So the next part of this talk, or I guess the third objective, is to discuss some common barriers to implementing naloxone programs. I want to pause really briefly, just so I don't talk for an hour uninterrupted if people have begging questions. This might be a good point to naturally stop and see if there are any questions for the audience on any of the prior points. If not, I'm happy to continue, but it may just be a natural stopping point if there are questions. We'll leave time at the end for questions as well.
A co-moderator has joined the conference.
Dr. Kim, we have not seen any questions come through yet, though someone just posted one in the public chat box if you want to address that.
Yeah, so somebody asked, how are you able to obtain the data on reversals for a program? So that's tough. So basically all the data I cited are from published reports. So these are people that have chosen to sort of build and sustain their own feedback program in terms of how they know how many opioid reversals have been reported, and they choose to publish that data. And so I don't think that there is a key central repository that we can look to and say out of all the take-home naloxone that's been distributed in Illinois per se, how many kits have actually been used. We're only reliant on people's anecdotal reports, published reports. And it's tough, even at our own program here at Northwestern. So we don't routinely call patients to ask them if they've used the kits. We have no way of knowing that they use the kits, except to know that patients sometimes come back and tell us that they've used the kits. But that all is just sort of dependent on luck for them to come back to RED to tell us that, hey, I used the kit you gave me, can we have another one? But I think the last time I checked several months ago, before COVID, we had distributed a little over 200 kits over a couple years, and we knew of at least 3 reversals that were performed in the community. There's not really a good mechanism for knowing how many of your kits have been used, except for just sort of relying on patient report. Some of the data is a little more reliable, like that opioid treatment program in New Mexico. They gave naloxone to patients that were actively enrolled in outpatient treatment, so they knew they were going to see them for follow-up appointments. It's a little easier to get that data, but yeah, it's going to be tough.
Dr. Kim, there's a couple more questions related to fentanyl test strips. Have you ever considered including fentanyl test strips with the naloxone?
No, I haven't. I actually don't know a good sort of a way of acquiring fentanyl test strips that patients can use. We use some for research purposes for the study we're conducting, but I think that it's probably not a very good use of our resources, in my opinion, just because I think that all patients should probably just assume that there's fentanyl in their heroin supply. If you looked at the data, over 80% of opioid overdose have fentanyl in their system. But I don't know, I kind of am a little hesitant to rely on something that might give the patient a false sense of security, like, oh, okay, this heroin is free of fentanyl, I'm good to use, because I don't know if the strips can really be accurate to that level. And I worry a little bit, kind of like with the COVID testing, somebody gets a negative COVID result, and you don't want them to be emboldened to say, oh, great, I don't have COVID, now I can host a 100-person party. It's not, it's not Not exactly true. So I haven't explored that personally in the emergency department. I see here somebody's posting something about distributing fentanyl test strips. I'd be curious to hear their experience at the end, whether they found it, the patients have reported it's useful. Looks like somebody says, I found it useful for patients who believe there's not fentanyl in their heroin. It's an interesting point. I'm grateful to hear the perspective in the community that they have been using them. Maybe we could talk offline. I'll post my email address at the end and talk a little bit about what your costs are and see whether it's a viable option. I think, my first priority would be let's make sure we can equip all our EDs and hospitals with take-home naloxone first. But this is an interesting point. Hopefully, maybe we can follow up offline. These two individuals that are posting about fentanyl test strips.
And Dr. Kim, there was also a bit of chat about referring to harm reduction from the ED so that they had not only the naloxone, but a referral to a harm reduction program. Just some comments on that.
Sure. I might leave that for Mike Nelson's talk just because he's going to talk a little bit more about buprenorphine and linkage to outpatient services. But again, I'll say that take-home naloxone is an excellent opportunity to open a patient's eyes to the resources we have available to them in the ED and the hospital setting. And we provide the numbers and the contact information for some local harm reduction services in our take-home naloxone kit. So absolutely, I would include that information.
And then one more
on yeah.
Sorry, did you see the one on what influenced your decision to distribute the IM kits in your ED versus the nasal product?
Yes, that is an excellent question, and I have a couple slides devoted to that in a little bit, so I will touch on that in just a little bit, but that is an excellent question. Thank you. So let's resume with the next objective to discuss some common barriers. Really, the information that I'm going to share with you is learned from my experience with different Chicago area hospitals that were all trying to implement their own take-home naloxone program as well a couple of years ago. And we banded together and had a bunch of conversations and published our experiences in this paper here, Take-Home Naloxone Program Implementation, Lessons Learned from 7 Chicago area hospitals. This publication is available to you in the resources link that I'll post at the end of the lecture. And there's a lot of different charts and information that I'll show in the following slides that will also be in that paper, so you don't have to feel the need to aggressively take pictures or write anything down. I think overall, the thing we noticed is that every hospital and health system is different. Obviously, some people have an easier time than others. There's different resources. There's different patient populations in hospitals. There's a different amount of red tape. Health systems, medical schools are structured differently. But it was remarkable that out of the 7 of us, there were still very common barriers and facilitators that were shared by everyone, no matter how your hospital or health system is structured. I would say out of all the barriers that we've faced, there were 4 common themes. The first was uncertainty about whether just handing someone a medication as they walk out the door is legitimate or legal. The second one is there was difficulty finding or funding a naloxone supply. The third barrier is that there was some staff resistance about whether administering or building a take-home naloxone program was a good idea. And the fourth one was just administrative bureaucracy that made the process of building a program really difficult. I would say in terms of barrier 1, this was generally sort of a comment from people early on in the process, whether that's hospital administrators or someone with pharmacy or emergency medicine or hospital medicine saying, I don't know about this. Are you sure this is legitimate? Like are you sure we can just hand somebody a medication? We can hand them needles. We can hand someone a drug as they walk out to the door of the hospital. And I think, when it eventually came to more specific questions that could be more well delineated, those went specifically into, 1, do we have the authority to dispense medication? We are not a retail pharmacy. This isn't Walgreens. We don't really do this. Are you sure that this is sort of allowed under Illinois statutes? And 2, what is our liability exposure if we do this? Can we face criminal prosecution? Is there civil liability? Is there any implications or consequences in terms of licensing? And so those are sort of the 2 specific things that it boiled down to in terms of the legitimacy or legality. Thankfully, the general question sort of early on in the process, if you encounter someone saying, are you sure this is legitimate? Can we do this? the fact that so many different hospitals, so many community organizations are doing this now really gives a lot of counter argument here. So it's very easy now to say, well, look, the U.S. Surgeon General, the Centers for Disease Control and Prevention all say that this is something that we should be doing. The American College of Physicians say that we should be distributing naloxone from the emergency department. They've even built a white paper and a toolkit that shows us how to do this. And if you look here, around us locally, all of the Chicago hospitals are doing it, everybody but us. So I think it's a very powerful tool to have in your back pocket to say, well, our competitors or our friends down the street are doing this. We're not doing it. Really, we're the only ones not doing this. So I think that's a good way to overcome just sort of this general barrier. And then specifically, to answer the question, do we have the authority to dispense a medication? The short answer is yes. I think first, in any state, you have to look at the Pharmacy Practice Act, which every state will have one that this essentially outlines, the regulations, the procedures for dispensing medications, what defines a pharmacy, what procedures they need to follow. And if you look at the specifics of the Illinois Pharmacy Practice Act, this is allowable as long as you follow standard record keeping and labeling requirements. And then there have been a number of statutes that have been passed recently over the last 5 years, like the Drug Overdose Prevention Program Law, the Good Samaritan Act, the Heroin Crisis Act. Some of these amend the Illinois Pharmacy Practice Act to talk specifically about things relevant to naloxone. And then others grant other protections, such as civil, criminal, licensing protections that overall can be extended to the practice of dispensing naloxone from the hospital or ED setting. And I think overall, each bit of legislation sort of establishes this broad umbrella authority for dispensing naloxone. I perfectly understand that it can be difficult. This is a chart that's in the publication I talked about that'll be available in the link. But it can be difficult to go to an administrator who's giving you pushback about implementing a program and saying, oh, hey, if you look at Section 1330.530 of the Illinois Pharmacy Practice Act, and you look at Public Act 099-0480 in this paragraph, and you look at the Drug Overdose Prevention Program Law in this paragraph, you see that we can do this. It can be tough to sort of weave all those different scattered fragments together, but thankfully IDPH, IDFPR, and DHS have built a document that sort of puts it all together in one that makes it much easier for you to take to your administrators and say, listen, there's a whole naloxone standardized procedure that we can follow here. And basically, it's a standardized procedure for appropriately trained professionals to obtain, dispense, or administer naloxone. This can include pharmacies, pharmacists, or OEND programs. It lays out exactly what procedures you should follow if you're a pharmacy or a pharmacist, or if you're not, how you should register as a drug overdose prevention program, how you should do so. It's really a great resource. So thankfully, that's all been put together, and you can easily just find it on the website. I've also included it in the Dropbox link at the end of the talk for you to download, as well as the Illinois naloxone standing order that you can use. Finally, I would just arm you with the anecdote that if somebody asks you, do we have the authority to dispense a medication, I would tell them that we are already doing this in the emergency department. And so we routinely give post-exposure prophylaxis after a sexual assault. So a patient comes into the emergency department, they, after a sexual assault, they routinely get free medications for emergency contraception, for antibiotics for STI prophylaxis, and if it's a high-risk HIV exposure, then post-exposure prophylaxis. So we're mandated to give these medications for free to patients so that we don't discuss billing with them, and it should be billed to a state fund. So we're already doing this. We package up the medications for them and make sure they have it when they walk out the door. So I think that anecdote is sort of one of the most effective tools we have. If somebody asks, I don't know if we can dispense a medication, I would tell them, we are already dispensing medications. And in order to answer the second specific question of what is our liability exposure, each of these laws that I've outlined below address these specifically. So for example, the Drug Overdose Prevention Program Law talks about how healthcare professionals who dispense naloxone in good faith and provide appropriate training are not subject to disciplinary action under a professional licensing statute. And then the Heroin Crisis Act expanded that to also include criminal liability. It also said that pharmacists who dispense naloxone in good faith are immune from civil liability. So I think broadly speaking, all of these different acts sort of provide an umbrella of coverage that says, we're okay from a liability exposure standpoint to dispense naloxone to patients as they walk out the door. Finally, I would say that there really aren't any known cases of medical negligence for distributing naloxone. In order to establish a case for medical negligence or medical malpractice, you have to prove 4 things: that there was a duty to act, that the care provider breached that duty, and that resulted in damage to the patient, and that the breach of the duty directly caused the damage. The key definition here is duty. A duty to exercise a degree of care expected of a reasonably competent practitioner in the same class to which the practitioner belongs, acting under similar circumstances. So what this means is basically we have a duty to act whatever is the standard of care, what another person who has the same level of training, who's practicing in the same context would do. And I would really pose the rhetorical argument of what is the standard of care in this day and age? 5 years ago, in the anecdote I gave you of a patient walking in asking for help and me just printing out the piece of paper that says, here's a list of clinics, good luck, I would argue that's not the standard of care anymore. December 17, 2020, the standard of care is for us to provide patients with solutions when they come in with an opioid overdose, that we either have a linkage to a community resource like a warm handoff, that we provide them with take-home naloxone, we consider inducing them on buprenorphine in the ED if they're withdrawing, or we talk about a home induction program. I would argue now that the standard of care is for us to do something and to have a policy in place like take-home naloxone or buprenorphine. I think actually if you look at relevant case law, there are abundant examples of cases of emergency physicians or hospitals being sued because they didn't have a plan for a patient. They released the patient. I'm thinking of one in particular. They released the patient after an overdose to jail, and then the patient died in jail after sort of an inadequate obs period. And the argument was, you did not do anything for this patient in terms of setting them up with a warm handoff to an outpatient provider. You didn't link them to any care whatsoever. So I would bring the opposite argument back to any administrators who are giving you resistance to say, I think we're at actually increased liability if we don't build a program, if we don't have a policy in place. The second barrier that programs talk about is finding or funding a naloxone supply. Obviously, in order to give someone take-home naloxone, you need to have the materials to do so. Typically in medicine, the way we approach care, like in inpatient and ED medicine, we provide goods and services to patients, and then we provide them with a bill later on the back end. But this doesn't really work for something like take-home naloxone, where we want to hand them the medication as they walk out the door. We're really not built to handle this from a billing and reimbursement perspective in the ED. We don't have a prior model for this. The only other thing that I mentioned about giving post-exposure prophylaxis for sexual assault, we don't go through billing or reimbursement at all because it's too complex. You're supposed to bill it to a state fund, and you're not supposed to involve billing or reimbursement at all. I would say that multiple EDs have tried to solve this billing and reimbursement puzzle. Like, what if we find out the patient's prescription drug coverage in real time while they're in the ED, then we can determine what their copay is, we can collect the copay, we can dispense the medication. It just doesn't work. It's way too much work. We don't have any mechanisms in place. We don't have the software in place. We don't carry like a cash box around the ED to collect copays, et cetera. There are just way too many numerous logistical challenges to make this work. And I would argue that, frankly, it's inappropriate for us to even to bring in this extra headache of billing and reimbursement for a life-saving medication like naloxone in the middle of this overdose crisis, especially with overdoses increasing in 2020. And really, I think the key feature of why this is difficult, again, is that the naloxone needs to be handed to the patient as they walk out the door because they could use again in the next hour, in the next 30 minutes. And really a central provision of that is we need to secure the supply up front so that we have it to give to the patient at no cost to the patient. I know that some other states like Massachusetts and Rhode Island have pursued like reimbursement codes from the state for dispensing naloxone, so the hospital who dispenses naloxone can bill a J code back to the state and be reimbursed. I think that's a step in the right direction, but honestly, my early conversations with people from those settings have been that it's a really clunky program and that it's not easy to use. I would argue, again, it's much more effective. It's a much more lean system for us to not even bring in extra paperwork, for us just to secure the supply and give it to the patient like we do for post-exposure prophylaxis. So one might reasonably ask, where do I even begin the process of procuring naloxone? I think there are a couple pathways. One, you can secure a donation from an existing naloxone distribution program, and two, you can purchase it through your hospital using your existing hospital pharmacy procurement process. In terms of getting a donation from an existing program, probably the best resource is to look at IDHS Super's list of funded OEND programs. They currently fund 12 opioid overdose education and naloxone distribution programs that cover all 102 counties in Illinois. So you can go to the IDH website. I'm also posting a link to this document in the Dropbox folder at the end of the talk. But you can go to the website or look at the document and find out what county you're in and find out what the relevant OEND program coverage is, and contact them to see if they're able to help with something like that. These are mostly community-based organizations, departments of public health, nonprofit organizations that are built to distribute naloxone in the community setting. A few of them have partnered with hospitals to sort of give them a seed donation of naloxone kits. But I would sort of reiterate that they're built for community distribution. There are some that have partnered with hospitals, so it's not a guarantee that they can definitely supply you with naloxone, but this is a good place to start. You can also purchase naloxone using your existing hospital pharmacy procurement process. This is a much better alternative than directly contacting a manufacturer on your own, obviously, because you can go through negotiated bulk discounts with your hospital. You don't have to worry about the process of receiving medications or finding a place to pick them up. Your hospital pharmacy can take care of that. But you'll need to find a funding source to use to purchase the naloxone after you've found sort of a place to get it or a price to get it at. I think that there are 3 possible funding sources. One is you can explore whether your hospital is a 340B program. And I don't want to get too much into the details here, but basically 340B hospitals are basically like nonprofit hospitals that provide safety net services to their community. The 340B program was created by Congress. It essentially allows 340B hospitals to purchase drugs at a discounted price, and then they're allowed to bill insurance companies for those administered drugs at the full reimbursement price. So you can imagine there's a gap. You purchase the drug for a lower amount at a discounted price, but you charge insurance the normal reimbursement price. And there's a little bit of excess funding that's created there that the hospital is supposed to use to subsidize their safety net services. And if your hospital is a 340B program, that's an argument you can bring forth to your administrators to say, listen, we're supposed to be providing safety net services based off these savings we get from 340B, and this is a great way for us to do so, and we can sort of justify our 340B program by saying that we purchased naloxone for community distribution. The other thing you can look into is the hospital charity fund. So a number of hospitals have charity funds. These are sort of the funds that are accessed when a patient can't afford their antibiotic prescription or an inhaler prescription and they're being discharged from the hospital or ED. Probably the best way for you to link to these is to talk to your social work department in your hospital. They probably know the best way to get access to these funds and approval to use the funds. And finally, there are a number of implementation grants that you can apply for to help you get your program started. Like one that comes to mind is IPHI, the Illinois Public Health Institute, has an implementation grant to participate in an opioid treatment learning collaborative, and there's some funding for either naloxone or buprenorphine programs. The third barrier that I've heard from people is that there's a lot of resistance from staff, and this can either be that staff members are saying, isn't this encouraging more risky behavior, like the moral hazard argument, or resistance from prescribers like physicians who don't want to serve as the prescriber of record. I think in terms of the first line of resistance, isn't this just encouraging risky behavior? This will probably be hard for all of us to believe that are engaged in this work, but there are a fair number of people that really truly believe if we give patients naloxone, if we give them the thing that will save their life, aren't they just going to go out and be more emboldened and just use higher risk opioids or use more frequently? You know, what I would really say to them is there is nothing riskier than, there's no more riskier behavior than the patient is already engaging in. A patient that presents to your hospital or ED with an opiate overdose literally died, and the only thing preventing them from staying dead was the naloxone that they were given. So, I would pose the rhetorical question, is there something riskier that this patient can do than death? Because that's what is happening already to these patients. We have a great amount of evidence now that patients who visit the ED for an opiate overdose have an exceedingly high mortality rate. So, in the following year, after an ED visit for opiate overdose, 5% of patients die overall. So that's 1 in 20. That's basically a higher death rate than anything we discharge a patient for in the emergency department or hospital. There is nothing else that we just release a patient for after a short ED visit that has a 5% one-year mortality rate. I would say in response to resistance about serving as the prescriber of record, you can use the Illinois Standing Order for naloxone. I've included that in the documents as well. You just put the IPHI directors, medical directors, NPI number in for the Illinois Standing Order. And then the last thing I would say to really sustain a program is to publicize wins among your department. You would be astonished how much it really increases morale and really can change people's initial thoughts. So I had a number of people who initially expressed some skepticism about giving up naloxone, and then when you see that patient come back into the ED and they say, like, I used the kit you gave me. My girlfriend overdosed and I used it on her and she was blue and she wasn't breathing and then she started breathing again. Like, I saved her life. Can I have another kit? And it really increases staff morale. I think there are so few wins in what we do in emergency care and hospital care, especially in this last year, that really hearing those anecdotes that, like, what we did mattered, that you saved somebody's life, can really turn people around and increase their enthusiasm for the program. And you'll really see in my experience, like, the ancillary staff and physicians are now like, oh, hey, can we give this patient a naloxone kit? This would be a perfect patient to do that for. So you'd be astonished. Finally, the last barrier that I've heard of is just this, redundant administrative bureaucracy that people say, I've tried to implement this program so many times, but there's so much endless red tape, and honestly, I'm just exhausted now. I'm totally out of effort. And this is the same at every hospital health system I've ever been at. It's like, oh, well, you want to build a take-home naloxone program? Well, you need to present that at the Committee for Medication Approvals, and then after that, you have to present to the Committee on Approving Medications. And you're like, I don't understand. Those sound like the same two committees to me. And then you get into some intricacies like, oh, one of them is for the hospital and the other is for the health system. You see, it's the same everywhere. There's so much red tape that it can really be frustrating. I would recommend a couple strategies. One is do your homework beforehand and come prepared to any sort of meeting or proposal you have. I think very commonly people just express that general skepticism of, are you sure we can do that? We can just hand people medications as they walk out the door. And if you do your homework beforehand and you have all the things I told you, all these different Illinois statutes, all these, IDPH, DHS documents that show exactly why we can do this, press clippings that show every other hospital around us is doing this, do your homework beforehand. It can be really helpful. The second thing I would do is just find a C-suite champion if you can very early in the process. This could be like a hospital CEO, CMO, department chair, whatever. You would be astonished at how much red tape can actually just be waved away by somebody with C-suite accessibility and say, you know what, I just want to get this done. Can you just please make it happen? And finally, I would say that it's really important to engage with hospital, ED, and pharmacy early. If you don't have a pharmacist on your team and you're trying to build an naloxone program, you need to get a pharmacist on your team. And if there are any pharmacists on this call right now, I just want to say thank you for all that you do. You're an incredible resource, and we wouldn't have been able to build our program without having the pharmacy actively involved. They're going to have much more familiarity with dispensing procedures, with labeling and record-keeping procedures, and how to access these medications. But overall, I would say the biggest obstacle is uncertainty, so just do your homework beforehand and come prepared. So finally, I want to talk about some logistical details related to building and sustaining the program, and I'll try to wrap up a little early so we have some questions, or time for questions. I would say first is how do you estimate how much supply you need? So how much naloxone are you going to need? Well, you could use the experience that we published of the Chicago area EDs. So between our EDs, we used about 4 to 12 kits a month, so just on average 8 kits a month. That comes out to 96 over a year. That's not a ton of naloxone kits that you actually need to build. So when you're sort of building out your budget, you could use 8, 10, 12, the upper range there. It's not an amount of money that's going to break the bank or is insurmountable. If you're practicing from a hospital setting, probably won't be as helpful to look at our ED experience, but you can run your own ICD-10 query to estimate your opioid visits and how many patients would be potentially eligible in order to get a take-home naloxone kit. I've included also in the folder link that I'll list again at the end of the talk, a list of ICD-10 queries that are relevant to opioid overdose that you could give directly to your data access person in order to run this type of query. The next choice is which formulation do you use? Again, I think the 3 most common ones are the vials and supplies kits, the Narcan nasal spray, and the multi-step atomizer kit. In my opinion, the The best kit to use is the vials and supplies kit, and then probably second best would be the Narcan nasal spray. And here's why I think so. It's based off a couple of studies. This first study was a randomized controlled trial conducted at a New York State Fair. So they found a bunch of laypersons and asked them if they would participate in this study at the State Fair about administering the 3 different types of naloxone formulations. So the single-step nasal spray, the Narcan nasal spray that we talked about, an intramuscular vials and supplies kit, or the multi-step atomizer kit. They basically looked at success rates and time to administration, and they found that the intranasal, the nasal spray, was slightly more usable than the intramuscular injection, so 67% compared to 52%, and that participants were able to deliver it faster, so 16 seconds versus 58 seconds. And really the take-home point is that the multi-step atomizer was impossibly hard to use. So the multi-step atomizer had a success rate of 3%, so pathetically low, and of the 2 people that were even able to use it, it took them almost 2 minutes to use. So I would say the multi-step atomizer is a very hard device to utilize. And if you look at the actual setup, it's easy to understand why it's hard to use. It's basically, there are a number of steps. It's like, I compare it to like assembling IKEA furniture while someone is overdosing in front of you. You have to take the yellow syringe that comes in the kit. You have to pry off the yellow cap both on the front and the back end. Then you have to take the vial of naloxone and pry off the red cap. Then you have to load the naloxone vial into the syringe, screw it in successfully, and then finally you have to take the mucosal atomizer tip and you have to screw it into the lure lock at the front of the syringe. You can imagine how difficult this would be if you're not a clinical, if you don't have a clinical background, if you've never done this before, and if someone is actively dying in front of you. It's hard to do. So I would really recommend not using this kit. And then in terms of which kit acts faster, like after you've actually administered the medication, the IM kit appears to have a faster clinical effect than the intranasal Narcan spray. That's why I say I prefer it. This is a randomized controlled trial that was conducted in Australia at a supervised injection facility. And basically, you know that in an injection facility, there's going to be a certain number of people who overdose and need to get naloxone to be rescued at the facility. And they randomized these participants to either receive IM or intranasal naloxone. This is a Kaplan-Meier survival curve, but essentially, of these 2 lines, you want the line to hug the y-axis as closely as possible. So you want a very steep drop-off. And basically, the steeper the drop-off, the closer you hug that y-axis means the faster that you have a clinical effect from the naloxone. So just to point this out, on the x-axis you see a response time of 25 minutes. That is the amount of time it takes to achieve a normal respiratory rate. In the IM naloxone group, at 25 minutes, 80% of patients had achieved a normal respiratory rate versus the intranasal naloxone group, in which 60% of participants had achieved a normal respiratory rate. They both eventually get there, but the IM naloxone group gets there faster. So in the prior example, the Narcan nasal spray was easier for participants to use. But in this study, after actually getting the naloxone in, the time to clinical effect was faster for the intramuscular naloxone. And the final consideration is comparing costs. So the vials and supplies kits is $13 to $15 a kit. The Narcan single-step spray is like $115 to $150 kit. The multi-step atomizer is about $66 a kit. And then the Evia auto-injector, like I said before, like the Tesla of Narcan delivery devices, is the most expensive at $178. And I think I saw earlier that somebody said that Evio or Kaleo no longer manufactures Evio. I wasn't aware of that, but I don't think it's a good option anyways. I would say all things considered, vials and supplies is likely the best option, and that's why we selected it for use at Northwestern. Finally, you'll need to meet a couple dispensing requirements like record keeping and proper labeling. What we did is we created a custom EHR order for easy tracking, so it's just called something like take-home naloxone kit. And the EHR order allows us to easily track who has received a kit, who's been dispensed a kit, and then we linked the EHR order to a label printer order that basically fulfills all of the Pharmacy Act labeling requirements. That includes things like patient name, prescriber, dosing info, etc. Another option that I've seen programs use instead of like linking an EPIC order to printing a label is using blank sticker labels that have the dosing info on it, et cetera, and then you fill in the name of the patient and the prescribing info. And then you also have to complete sort of an additional copy, a record-keeping copy on your end as well. Finally, in terms of patient education, you do have to provide opioid overdose education. I think it's best to utilize a non-physician educator, honestly, and I'll talk about that on the next slide. But IDHS has education and training materials available on their website. You can just print out. There are videos to watch. They've really made the process very easy for you in terms of building up the educational part of the program. My point overall is that the entire process should be really easily triggered. It should be efficient. It should be automated so that if something comes into the emergency department or the hospital that distracts your attention, like suddenly get a gunshot to the chest or you get a patient that emergently needs to be intubated, this doesn't, get pushed aside. That as soon as somebody says this patient should get take-home naloxone, you should have a process in place so that it happens, so that if you get distracted, which honestly happens a lot during COVID now, that the patient still gets his naloxone. I think initially in March and April when COVID was just starting, we noticed our take-home naloxone dispensing was dropping off. And I think it was because patients or providers were just so distracted with new COVID patients coming in, wondering whether we had enough PPE, that their attention just wasn't focused on take-home naloxone as much. And that's a great argument for why the process should be easily triggered. It doesn't require a lot of work and that it should just happen. And finally, it should be democratic, where anybody, any provider can say, hey, can we give this patient naloxone? And it happens. So that means nurse, physician, social worker, pharmacist, medical assistant, medical student, anybody can say this patient would be great to get take-home naloxone. Can we make it happen? There shouldn't sort of be a threshold to apply where it has to have the approval of somebody higher up. We should just make sure it happens. It should be easily triggered and democratic. This is a table from our paper, and the only thing I want to highlight here is that every program that's been successful has utilized a non-physician educator, so either an ED or inpatient nurse. Some of them showed videos, some of them didn't. A pharmacist, either an ED or outpatient pharmacist, to do the education piece. It actually doesn't take long, like anywhere between 5 to 15 minutes to show someone how to use naloxone. But I did talk to one program, an ED-based program, who tried to have this all be physician-based. It just didn't work. And this isn't necessarily to try to push work off the physicians because we're more important or something. It's just simply a matter of staffing ratios, that there's fewer physicians in the ED or in the hospital, and so their attention just is constantly pulled in different directions. And if you rely on the physician to do the education, then it just may not happen. So I think the one practical point I would give you is it'd be best not to rely on a physician educator. So just briefly going over what we talked about again, we described some recent trends in opioid overdoses. We talked about how initially we were making some progress both in Illinois and nationally. There's a plateau of opioid overdose deaths, but they've increased again in 2020, maybe due to COVID. Hard to say for sure, but one thing's clear is there's a clear pattern of increasing opioid overdose deaths. We talked about some different models of naloxone distribution. We said the gold standard is direct dispensing, delivering take-home naloxone, which means handing it to patients as they walk out the door because that's when they need it, and it bypasses all the known barriers to prescription refilling. Talked about some different distribution models, community-based, jail-based, and hospital ED-based. But no matter the setting, naloxone distribution works. We're talking about an 18% success rate or an 18% utilization rate. We talked about some common barriers, such as uncertainty about the legitimacy or legality and how to address those barriers. I specifically equipped you with different resources like the exact statutes, the IDPH, IDFPR, DHS standardized procedure, and the anecdote of, we're already doing this now. We're handing out medications for prophylaxis after sexual assault. And we've talked about some different resources you can obtain, like donations from existing OEND programs or exploring whether a 340B discount would work. And finally, we've described some key logistical details, like which kit would be best to utilize. Again, I would recommend either the vials and supplies kit or the Narcan single-step spray. And some very easy tips for success, like utilizing a non-physician educator and building sort of a custom electronic order that makes all the tracking and label printing easy. So again, thanks for your attention. As I said, all references can be accessed at the following link. I'd be happy to answer questions by email offline if anybody has any, and we have about 15 minutes to answer questions now. And I'm going to start reading through the questions now as we also say them out loud. But I'm already grateful for the information that I've learned from you guys in this talk already. For example, regarding fentanyl test strips, I think it would be great if whoever's doing fentanyl test strips can email me afterhand. I'd love to have an offline conversation. We haven't done that in the ED, but given that it's been successful in the community settings, I think it's worth exploring at least. And happy to answer any questions now.
Dr. Kim, there's one in there about hospitals bringing people in recovery or recovery coaches or treatment providers to help advocate for patients while they're in the, I believe while Barbara's referring to while they're in the ED. Do you have some comments on that?
Yeah, I think it's great. I think that Mike may touch on this a little more because I believe Mike works at one hospital that does have peer recovery coaches. I've heard a lot of success about them. We don't have them currently at our hospital. I would love to have peer recovery coaches. I think we were in the process of sort of talking about that, and then COVID came about, and initially there was, oh, well, we have to reduce all unnecessary staffing just to reduce people's risk in the ED. But I've heard a lot of great anecdotes of success. I think certainly it's a much different thing to have a doctor come to you in a white coat and tell you this will help you versus having someone who has the lived experience of using drugs, who's walked in the patient's shoes and can talk to them from that perspective. So I think it's great for patients to have. I'm totally on board with that. But I think Mike will talk about it.
And there's a question about clinical dosing for naloxone. While looking at how many overdoses are fentanyl and fentanyl analog related, are there clinical considerations for giving naloxone dosing?
No, I think in terms of dosing, like 2 milligrams, 4 milligrams, 0.4 milligrams, I would say no. We haven't factored that in. I think part of it is fentanyl is so unpredictable. That's what makes it dangerous. It's hard to predict what dosing response would be good. I think that the point I would make is that's why we give multiple doses in each naloxone kit. So every take-home naloxone program I've seen gives at least 2 doses, and that's exactly for the reason, in case the first dose is ineffective, maybe there was a massive high-potency, fentanyl analog in there. You should equip them with a second kit that they should use after a certain amount of time. But I don't think that changing the dosing is really the solution there, mostly because the dosing is driven by the manufacturer.
Okay. And then going back to that question about bringing recovery and treatment folks into the ED, not only for the patients, but also do you think that would encourage more hospitals to embrace programs like this, or if there's any need for the hospital physicians or nurses to be more on board, do you think that's a way to do that?
Yeah, I don't know if bringing the peer recovery coaches overcomes the sort of administrator or nursing or physician resistance to having these type of services. I'd be interested to hear others' experiences, especially Mike, but I don't know that would be the hurdle that gets you over. I would think it's more something that the patient appreciates in terms of having someone who has lived this experience being there to help you. I do think that the ED staff, the hospital staff, would appreciate sort of the assistance and sort of offloading some of this, some of the work that's necessary to engage these patients onto somebody else. We always love more assistance, especially like in the ED where we're constantly, doing 100 things at once. So I think the staff would love the extra help. But in terms of if they're initially opposed to the idea of it, I'm not sure. I don't know that I can give you a yes or no answer. I'm curious to see what Mike has to say.
Thank you. And just one follow-up question. Do you think that discharge information on harm reduction and treatment is something that people can influence, making sure that those resources are available? We have lots of folks statewide on here that would probably like to have their information available to patients that come into the ED. Any recommendations on that discharge information and how to get your information out there?
Yeah, so it's a good question. I really perceive that a real problem we have in linking patients to outpatient resources is that there's no single repository of all the different outpatient centers there are. So, the common problem I see in the ED is a lot of patients come to downtown Chicago and they overdose and they come to our hospital, but they don't live in downtown Chicago. They live in the west side, the south side, or in the suburbs. And, I say, well, I have the contact information for our partners downtown. We have a couple of clinics that we partner with here, but I don't know anybody that, I don't know the Naperville clinics that well. So, it's been a goal of mine to sort of establish a bigger repository of this information. And please, if one already exists, I would love for someone just to tell me about it. But, towards that end, if you just want to email me your information in terms of like where you are and what services you provide, I will begin compiling a document sort of that I can make available that you can have on hand to say, oh, this person lives in this part of town or in this city. We know, we have the backline phone number for their staff for scheduling.
And Barbara Smiglio has mentioned that the helpline has a compiled list and all this information.
Oh,
so
great.
The hard part there is making sure as providers that you inform them of any changes and keep that information up to date. So good opportunity for everyone here to take a look at their information that's available on the helpline and make sure it's accurate. There's a question about, do patients ever decline taking naloxone when it's offered? If you have that conversation, what does it look like and how can you encourage them to take a kit? And then lastly, can a kit be supplied to family or friends?
So the first question about do patients ever decline, I've never had a patient decline. I have had multiple patients leave their kits behind, which, it isn't really their unwillingness to take the kit, it's just more they forget to take it. In terms of having patients decline, I have had patients say like, they were brought to the ED because they overdosed in public, they received naloxone by the ambulance, they were brought to the ED. And when I start to talk to them about, oh, I'd like to provide you with a take-home naloxone kit, they tell me, oh, no, I wasn't using heroin. I wasn't using drugs. And, that's just the natural reaction of the ED is not a safe space for them. Like, they don't feel comfortable here. They don't feel safe here. They don't want to tell the truth about what happened. And so that barrier has not been, insurmountable. For me, I just say, listen, I'm not the police. I just want to help you. I just want to give you a free naloxone kit. So I totally understand if you weren't using heroin, but I'm just going to give you this free medication and I'm going to teach you how to use it. So if you're ever around somebody that uses heroin and they overdose, I want you to be ready to save their life. And this is totally free to you. Can I just give you the kit? And everybody has said yes to that. And then the other question was, sorry, I'm forgetting the other question now. Friends and family is a little more difficult. At least the way we've set up our program, you have to dispense it to a patient because you have to enter an EPIC order. I think there's probably a way to set up a program creatively, like community-based programs register as drug overdose prevention programs and can distribute them broadly to any community member. So I think it would probably, you'd have to go through that route of setting up as a drug overdose prevention program within your hospital. It's possible, but right now, depending on the way you set up your program, like for us, we only dispense to patients.
Okay. One question about multiple doses of naloxone impacting respiratory issues. Have you seen any evidence of that?
No. Is that like the pulmonary edema? I'm sort of guessing. There's a phenomenon where, after patients overdose and receive naloxone, they get pulmonary edema, which is fluid in their lungs and difficulty breathing. We're actually not sure of the pathophysiology behind that or the mechanism behind that, and it's unclear whether it's related to the initial heroin dose or the naloxone. So I don't have a lot of information about what drives it clinically or how to avoid it. I think that our approach to giving out naloxone in the community should not change, though, because when I'm weighed between sort of the two options of somebody overdoses on heroin and dies because they're not breathing versus they overdose, we reverse the overdose, but then they have breathing issues as a result, I think I would still, the lesser of two evils is reviving them, and if they're having breathing issues, they come into the hospital. It's still a small minority. I think Mike probably has more expertise on that topic as a toxicologist, so he can talk about it a little more maybe if there's time.
Okay, this next question is about the percentage of emergency departments that are routinely engaged in a naloxone program. Is there a wide-scale data source that exists?
There isn't like a registry. It's sort of all word of mouth. It's people saying, oh yeah, I know that there's a program at Northwestern. I know that there's a program at University of Chicago. I know that there's one at Christ. So it's just word of mouth, really.
Dr. Nelson, did you want to jump in there a second?
Yeah, I was going to say the post-Narcan pulmonary edema. The theory is that with the giving the naloxone, that right afterwards they kind of come up and they go into immediate opioid withdrawal, and it causes a catecholamine surge in their body, which is like a release of adrenaline, norepinephrine, epinephrine. which then causes the vasogenic edema to fill up in their lungs. And that's the prevailing theory. Obviously, testing that is impossible, but that's what people think it is. So that's why, as you've seen in the medical setting, instead of just giving the standard 2 milligrams like EMS will give, we'll often do smaller doses, like even starting at 0.04 or 0.4 milligrams. Like our purpose isn't to wake them up. It's like you said, just to get them breathing. So you just give them just enough to get them breathing where they don't need oxygen supplementation or to be intubated. So so you'll give minuscule amounts of the naloxone to prevent that potential complication.
Yeah, I think that would be tough for somebody to titrate that dose, like if they were a community member. I think it still might be best just to give what we believe will be the most effective dose, given how infrequently pulmonary edema happens. But yeah, thanks, Mike. That's a great review for me.
Yeah, no, of course. And that's why in the
question,
community setting, just get them breathing, you know?
Yeah.
This next question, I think both of you might be able to respond to. Have you found a preference by opioid use disorder patients in the route of administration for naloxone, nasal or IM?
No, I think part of that may be the fact that we only offer the intramuscular kits. Sometimes patients will say like, oh, I'm, I really don't like using needles. But it's never been a barrier where they won't accept the kit. I've heard more anecdotes of like hospitals being like, we don't want to give out needles. We want to do the Narcan nasal spray, which is fine. If that's what you need to convince your administrators to build a take-home naloxone program, then I would just accept that. Overall, I think that's kind of a silly argument, though. Like, if you're concerned about giving out like free clean needles to patients, I would argue that your perspective is just wrong. It's totally fine to give out clean needles to patients to use in a naloxone kit. It's not going to enable their drug use more. And if anything, the patient just has clean needles instead of dirty needles. So personally, I haven't found it to be a big patient issue. I've heard more that administrators are like, we don't want to give out needles. And then I've heard of some programs, like there's one program I'm thinking of that has a naloxone program specifically in the psychiatry, like inpatient psychiatry unit. And they obviously don't want to use any kits that have needles because it would be a safety risk. Like any patient that's admitted to an inpatient psych unit can't have anything that can hurt somebody else. For example, like if they break their arm, we can't put a hard cast on their arm because it could be used as a weapon. So that I totally understand.
And then there was a comment that by having a treatment provider in the ED, it just with some of the conversation and linkage off of the emergency department staff, and it seems to be a good two-way opportunity to work with somebody. So the treatment providers are saying it's been very beneficial for them, as well as I think what you said.
Yeah, I think I would say that every time we have added an additional resource to the ED staff to help them offload some of the burden, they've loved it. So I think if you've gotten past the initial barrier of, staff being like, I don't think we should do this, and, your physicians, your nurses are on board, then they're going to love having additional resources. Like we added a pharmacist overnight, everybody loved it. We added a social worker every night, everybody loved it. We added a physical therapist to the ED, everybody loved it. So in general, just the way we work in the hospital is if you're going to give us extra help, like we're going to embrace it. We're going to give you a hug and say, oh my God, thank you so much. So yeah, peer recovery coaches are awesome.
So we are coming up on a break here, but you had touched on having someone in the C-suite be a champion or on board. Any other tips for people that want to engage their local hospitals in a program to distribute naloxone?
No, I think that's about it. It's the ones I shared. Like it's really helpful to have someone in the C-suite on board that gets rid of a lot of the administrative red tape. I would say you have to make sure there's somebody from pharmacy on your team. And I would say the biggest thing to sustaining a program is find a system that really just sustains staff morale. Like publicize when a patient comes back and says that they use the kit. If there's a venue to have them come back and talk to the staff and say thank you, that would be huge. Like I know a big thing that increases staff morale for us is if there's like cardiac arrest patient in the ED that we actively gave CPR to and resuscitated. Like if they recover and they're completely back to normal and walking and talking, if they come back into the ED and say thank you to the staff, then people are like in tears, so happy that what they did mattered. So I would say build a system to increase staff morale. And then finally, just to make sure that your entire process is lean and that it's automated, because things are going to happen. Like, when COVID hit, we just didn't distribute as many naloxone kits. You want to make it as low barrier as possible so that it happens very easily and very quickly.
All right. Hopefully everyone is back from break. I'll give everyone just a few more seconds to get back on the computer and we'll get going. Just want to say again, thank you to everyone for being part of this today, and thanks to Dr. Kim. You're a tough act to follow afterwards. Hopefully I can do just as well. So excellent. So let me introduce myself. My name is Michael Nelson. I'm an emergency medicine physician at both Cook County Health as well as at North Shore University Health System up in the northern suburbs. I'm also a medical toxicologist. I work with the Illinois Poison Control Center, as well as an addiction medicine specialist, and was doing doing an MAT clinic out in North Shore, and very likely starting to do some addiction treatment stuff out of Cook County in their MAT clinic as well too. So I wear multiple hats. And, have seen things through a broad spectrum of this as well too. The obligatory disclosure slide, I have no financial relationships to disclose. I'm not going to discuss any off-label or investigational use of medications during my presentation. But like Howard, I will just say, for the one disclosure, had very kind of multiple similar experiences to what Dr. Kim had as well too, saying there had to be a better way of doing this through my emergency medicine training. And I grew up in the training of the prescription opioid area of, if you treat people's pain, they're not going to get addicted. Keep treating their pain, keep the customer satisfied, and keep the prescriptions coming, because it's going to keep them happy, it's going to keep them out of the ER, and they're not going to get addicted. And that was the training from the late 90s through the 2000s. And I remember thinking that, this is crazy in terms of just giving out pills after pills after pills for like ankle sprains to 14-year-olds, and but that was what we were instructed to do. So it was kind of an eye-opening experience then to start seeing the overdoses start rolling into the ER, and I kind of hear that same story over and over of, I got started on the prescription opioids for this pain, and then it escalated, and then physicians cut me off, and then I went to the street because it was actually cheaper to get the pills, and then it escalated to heroin, and then that escalated to this overdose that you're seeing today. And then going on and doing toxicology, starting seeing the public health perspective for just big outbreaks of overdoses, and kind of detecting the fentanyl that was in the late 2000s, early 2010s, and then really again saying, why are we doing this kind of pattern over and over, and what resources do we have, and always feeling inadequate in terms of those resources with giving that handout sheet and saying, here you go, make these phone calls, that we weren't really doing anything. So that kind of spurred me wanting to do addiction treatment to try and help move that needle a little bit. But I do think when we're talking about starting any type of treatment out of the ER, we really have to understand what the ER does as well as the workflow of the emergency department, because it is an extremely hectic place. So as we kind of go through our lecture, we'll talk about that ER workflow, a lot of the barriers to initiation, the evidence behind buprenorphine, and sometimes I'll just call it bup. That's kind of what we'll say instead of buprenorphine over and over again. How we can develop some plans for linkages to treatment, including kind of layered in with all those harm reduction resources, and how do we build capacity for our hospital systems and ER to initiate that. So this is your actually average day in the life of an ER right here. And many people don't perceive this because potentially when they're a patient in the ER, they're just in their one room and they don't see all the other stuff that's going on outside of there. But you often have the maintenance guy doing some work over there, somebody delivering food for the staff, because we're eating on our feet and on the run. We're rarely taking breaks. You have surgeons consulting down. It is quite a hectic and chaotic place. And actually some studies have shown that the average ER physician gets interrupted once every 2 minutes. Imagine that. If you're trying to sit down and write a paper and somebody's sticking something in your face or asking you a question, how easy it is to lose train of thought. Or you're trying to put in orders for something and somebody comes up saying patient in room number 9 wants this, and a family member in room 10's here, and the doctor's on the phone for you over here waiting, and you can easily lose track of what you're doing in that one time, because often that physician is managing 15 to 20 patients by themselves, or potentially with some minor help in terms of the nurse practitioner, physician or assistant, or resident physicians. But you get pulled in many directions very quickly in the emergency department. And the ER itself is healthcare and society's filter. And think about it. Like, if the doctor doesn't know what to do in the outpatient office setting, what do they say? They say, go to the ER. If family members don't know what to do, they say, come to the ER. If police don't know what to do when they have a patient or a person that they've arrested and they bring them to the ER. So essentially, the emergency departments are healthcare's as well as society's filter. So you get this big mess of everything kind of intertwined all in one place. And you have to decide what to do with them in time constraints in a hectic, chaotic environment. So it can put some strains in terms of that physician and where they're at. And there's a lot of misconceptions behind what the ER can do. A lot of people think it's a one-stop shop, that everything's going to get fixed in just 2 to 3 hours, and if it's more than 3 or 4 hours in terms of the time they're unhappy with that, and get them in and get them out kind of thing, and that everything should be done right away, and that they're going to get definitive answers in those 2 to 3 hours to most of their problems or issues. So a lot of people see it as like an on-demand medicine, 24/7, all access. And part of that is the emergency department's fault to begin with, because we do what we do so well in terms of moving people through and getting them out and getting people a lot of answers, that it's grown steadily since the field of emergency medicine was started in the 1970s. And emergency medicine itself is one of the newest, like, primary fields in medicine as a whole. And it's kind of like shocking when you think about it like that. And the other misconception is that everyone has the same knowledge base, that we all have the exact same level of things in terms of the tools we're equipped with. But in reality, we have a lot of resources, but we're also limited in resources. Like, you're not getting mammograms. You can't just walk in off the street and get a colonoscopy. You're not getting your PET scans or biopsy results or any of these other things done for those definitive answers. But you do have the resources you need to stabilize life-threatening emergencies. And most of our physicians are actually relatively bad at chronic or long-term disease management. They are very much what's now, is it going to kill you now? Or if it's long-term disease management, that's not the training. And think about it, that's like the outpatient primary care, that's your longitudinal care doctor's training, versus emergency training is what do you need to stabilize the disease right now to get them to the treatment that's there. So often they are risk stratifiers, and some of the best risk stratifiers on the planet are your emergency medicine physician doctors. But we're not often very good at definitive answers. It's what we call sensitivity, meaning we're able to rule out diseases, versus specificity, meaning give you specific disease answers right away. And most components of specificity have time components involved in that. But emergency doctors will move mountains for true emergencies. Unfortunately, though, that does lead non-emergencies to wait for resources available. And there's different knowledge bases amongst providers. So each provider you're going to get will have a different kind of viewpoint. And to put that in perspective from the knowledge base, there are more than 135 specialties and subspecialties in medicine as a whole. If you add up all the specialties, subspecialties, and years of training, it accumulates around 250 to 300 years total of training in order to know the breadth of medicine, which is just impossible for anyone to do. But the ER physician knows a little something about a lot of those fields. And all those fields, however, expect the ER to manage their patients just as they would. So you can see that it's like Sisyphus pushing a boulder up the mountain. You're never going to get to the top, and you always have this weight pushing down on you. But they truly are masters of life-threatening emergencies in these fields. And the demands over time have just grown exponentially on most physicians. For instance, there's sepsis bundles, CHF bundles, stroke protocols, as Howard mentioned earlier. Door-to-doctor times are measured, door-to-discharge time, door-to-floor times, patient satisfaction scores, door-to-balloon times, radiology ordering guidelines that you have to click certain orders and make sure each kind of click is done. Your documentation requires your yearly CME, your opioid CME that you have to get 3 hours for a year, your certification requirements that you have to constantly do it. So it's click after click after click, which has been well described in medicine, death by 1,000 clicks, over and over and over in terms of literature. So in reality, what we wind up seeing is that a lot of times the doctor is sitting there at the computer doing things instead of doing what they really want to do. And the physicians really want to be here, right here, at the bedside with their patients. A lot of studies have shown that most physicians are actually here. About 50% of their time is spent at the computer, where only 30% of the time is with patients. And the other 20% are the in-betweens, like walking to this room and back, answering this phone call, talking with consultants, doing other things. So you can see a lot of your workflow is spent clicking, clicking, clicking. So when we start thinking about things we need to do, or when we start thinking about the emergency department, it really is organized chaos. And like we give the analogy of spinning plates. You're constantly trying to keep those plates up instead of one falling and crashing on you. So if you want things to work in the emergency department, it has to be easy. You have to take that load off the physician as well as the staff and create resources and systems that really streamline things for you and make it simple on them if you want adoption, because just things keep adding up, and it's like the straw that broke the camel's back. Everyone thinks, well, we're just going to have them do this one extra thing. Each field thinks that in all of medicine. We're just going to add this one extra layer on. So addiction treatment is no different. It's like, well, why can't the ER just handle this and deal with this? They're open all the time. They should be able to do this. It should be an easy thing for them. Unfortunately, the systematic processes in place do not make it easy. And when we're thinking about building a program, any program out of the emergency department, you really have to take work burden off for adoption of that program. And then you'll have instant buy-in, like, oh, you're going to save me time and save me resources and extra things I have to do. Of course I'm going to do that, because then I can spend more time seeing the people I need and more time at the bedside with people. Because at the end of the day, this is what physicians want. We want to make a difference. We want to improve health. We want to be there at the bedside. So there are some simple things that can be done, like, for instance, and it make it a little bit easier on you. You can click on that 4 arrow icon at the top, and it'll expand your screen because my picture kind of turned out a little blurry here. But to decrease some of the documentation burden, you can create templates for the physicians that, hey, you can use this. You can build in a COWS calculator. That's the clinical opioid withdrawal scale calculator. And this is a screenshot from a county for me. The COWS score is built in right there, just on our top board. So if we hover over a patient's name and just click COWS calculator, it pops up with this little calculator. You click the buttons for it, and it tells you the COWS score, and it automatically documents it in their chart for them. And it's super easy and fast, rather than me having to go to another web browser if I don't remember all the little subtleties of the COWS scale and trying to pull up MD-Calc and typing everything in. You're less likely to have an adoption for that. And as we've seen through PMP, or the prescription database monitoring, when people had to log into a separate website, only 17% of people actually utilized it, versus now when we have integration of the prescription database monitoring into the ER with DHR, which literally one click and it pulls it up. It's the widespread adoption and use of it is just overwhelming. So if we want to get things working for our physicians, we need, and our care teams, our nurse practitioners, our physician assistants, we need to make it simple for them from the system standpoint. And despite that, though, those are just minor barriers. There are multiple other barriers in terms of how we're going to deliver care and provide care to our patients. There's a nice study done by Lowenstein et al. That talked specifically about barriers and facilitators in emergency department initiation of buprenorphine, particularly looking at the physicians and what they thought it was. As you can see all the way down here, like less than 30% of physicians felt comfortable initiating buprenorphine in the emergency department. That, it speaks like, look, if not even half your physicians are comfortable, they're less likely to adopt this into their practice. And that they didn't feel that they had the resources that were needed to take care of these patients as well, too. So I can just play with my screen a little bit here. Okay. And it kind of looked at those physicians that had gone through waiver training versus not going through waiver training. You could see, though, there's big discrepancies. So the second little line here showed the physicians that had gone through waiver training felt much more comfortable at actually initiating buprenorphine. And I don't expect you guys to read all these little things. I'll sum it up for you in one little slide. And kind of broke it down even further. So what they kind of saw was that there was a lot of concerns for induction logistics, like how do we induce people on buprenorphine, that they were concerned about reimbursement challenges. Well, if we're doing this, is our department getting the money back? Is there more time constraints involved in this? They were concerned that the scripts that they're going to get were going to get diverted like other opioids that are out there. He felt like there weren't a lot of support at helping manage these complex patients, that essentially there was a lot of nuances behind them, and that they weren't well equipped for that, that they had lack of psychosocial support, social work, psychiatric counselors available to them, and that it just wouldn't be sustainable if they didn't have those systematic resources put in place. So we kind of look at these barriers a little bit more in depth, kind of break each one down a little bit between financial, regulatory, geographic stigma, and logistics, and the individual barriers. Essentially, every one of these barriers, though, lead to reduced access to care, which, as we know, is a major problem for any disease state. So our financial barriers, like our system itself is set up as a fee-for-service system that you get reimbursed for the services you provide. And unfortunately, there are a lot of out-of-pocket expenses that are there, that if you don't meet your deductible, your copay, you pay the XYZ out amount, or if you don't have good insurance coverage, these resources limited to you can only access these resources. That depending on your insurance itself, there might be poor reimbursement for the services you provide. So you essentially create a hierarchy of private insurance, a PPO and HMO reimbursements versus Medicaid reimbursement, which then incentivizes systems to set up care tailored for individuals that have good insurance. Potentially either got to pay for all this all cash out of pocket, like your classic Minnesota model, like clinics that are completely standalone, not associated with healthcare systems, versus your hospital systems that say, sure, we'll take this person, but what's their insurance first, before they accept them or don't accept them. And then you need prior authorization a lot of times, so it does prevent these barriers. If you have a patient in front of you and their insurance doesn't allow for this medication to be written, it'll get denied at the pharmacy, and then you have to try and but it's the best medication for them, and then you have to go through all these hoops and hurdles to get them that medicine. There are regulatory barriers as well, too. Obviously, when it comes to buprenorphine, the X-waiver requirement itself, and you have prescribing limits where you can only write for 30 patients in your first year, or 100 patients if you have subspecialty training, or 275 if you apply every year in order to have that requirement. Our opioid treatment programs obviously have a lot of other federal and state regulations they have to go through to be able to provide methadone for people. There's zoning regulations. Certain communities don't want these type of treatment facilities or these patients in their backyard. And we've seen a lot of places not adopt this in the community because of those concerns, and that ties into the stigma of opioid use disorder. And then you're required to have access to counseling, and unfortunately, as we've seen too, there might be long waits to get into a counselor or a treatment provider that are out there. Geographically, there is medication-assisted treatment area deserts. The patients themselves will have lack of transportation to get to these areas where, if you're at an OTP program, you have to go every day to get your methadone, or if you're a buprenorphine provider, you have to go in once a month, or even if you're high risk in the early phases, it was like having you come back every week to be seen until you're stabilized before then coming all the time. And in a lot of our physicians in more rural areas, there's a lot of lack of support regionally for where they can send people, or if they have a complicated case or a patient doesn't seem to be responding well to treatment, where they're going to be able to send this patient for further treatment and care. So you can see that would lead to that physician saying, look, I don't want to take this burden on and have to bear that weight myself without having any backup whatsoever. And when we look at some of our MAT data, this is from 2017. You can see there's just large swaths of areas, and clustered around Chicago and the suburbs, tons of providers, and you kind of see a few other areas like around Champaign, Peoria, St. Louis, but just tons of areas where we didn't have medication-assisted therapy. Now, one of the really cool things that we have seen over the past couple of years, and thankfully a lot of efforts by the state, is that this is from August of 2019. We've increased our MAT capabilities throughout the state quite a bit, not to the point where we want to be. Obviously, we want to have it just kind of ubiquitous no matter where you go to have this kind of build out, but have made strides in improvement. And kind of just as a different view for people, these really dark areas or these MAT deserts in 2018. So you can see large counties didn't have any areas without any access to treatment. And some places only had like 1 or 2 buprenorphine providers from the entire county. And this is one of our most recent kind of data and maps. So you can see we're starting to even build that out further and further as time has gone on, and we're starting to move this or break down some of these barriers and have grant programs available for people over these couple of years. So we are making progress, right? But not to the point where we necessarily would like to be. But we know these things don't happen overnight. So things are moving in the right direction. The individual themselves has to be ready to change. It's something that was kind of alluded to, like, people had resistance to wanting to take naloxone. And it's what we in the world of addiction medicine will say, we're moving from the pre-contemplative stage where they didn't even know they had an issue or a problem to the contemplative stage, where now they're saying, well, maybe I do have a problem. Maybe I need help for this. Maybe I can't do it on my own. You're also dealing with co-occurring diseases. A lot of people, because of their substance use, will have untreated diabetes or high blood pressure or secondary complications from their substance use that has created other issues. And then once you start getting them in treatment, how do you also manage these other disease states and coordinate care for the person? And that really does lead to making individualized treatment plans for a complex disease state that is there. And we know that it's much better when you're able to pull in family and social support. People are much more likely to engage in treatment and have ongoing treatment when all these other social support services are involved in their treatment care. But unfortunately, a lot of times their substance use has ostracized their family members, or family members have given up on them and said, I'm done with you, don't come back. And we know that just drives a lot of these individuals further and further down. And unfortunately, then those individuals, too, will have financial constraints, as we've seen. Because of their substance use, they can't hold down a job. Thus, they don't have good insurance coverage. Thus, they can't get treatment. Thus, they use substances because they're depressed, and it creates that downward cycle. Logistics, lack of counseling, coordination of care. There's wait lists to get into places, lack of infrastructure for providers that are there. Those time constraints on the providers. Like your outpatient primary care doc is boxed into 15-minute visits, 4 patients an hour, and just nonstop in order to meet the financial demands of their job of getting people through and through. But unfortunately, when you get somebody, you have to really sit down and have a counseling discussion with them, talking through this. Be half an hour to an hour of actually starting to walk them through, and it destroys their day. And same in terms of their patient flow. And it can destroy that patient flow for them. And that's why then, unfortunately, the person that had a 4 o'clock appointment is waiting until 5 o'clock, and then they're upset and frustrated, right? And then, obviously, with that, you get poor reimbursement. So where's the incentive for the provider if this person has Medicaid and they're getting 16 cents on the dollar versus a PPO, Blue Cross Blue Shield, that's getting 60 cents on the dollar for the reimbursement, where you're have to see 4 of those patients to equal 1 of the other. So there can be those logistic barriers for the providers wanting to take on this patient load. And then, of course, stigma. We've heard this too many times in the community as well as even in medical fields, where they say, why are you going to help that person? It's just another addict. Or people they drop dirty on their urine. And that just even confers like that degree that their urine's contaminated or dirty. Or an addicted baby. And we know babies can't be addicted. They might be dependent on opioids. They're not addicted, but these terms have all been thrown out there. Or that we're substituting one dependence for another, when really we're trying to stabilize their opioid use disorder and give them back their life and get rid of their addiction. We're not treating their dependence, right? And that distinction needs to be made, the difference between dependence and addiction. Or that people can just choose to quit. And we know that is not the case, and that we viewed this as a moral failure. I mean, one of the nice things that has come over the past 4 or 5 years, particularly with more widespread knowledge of the opioid epidemic, though, is that there really has been a shift of focus, that this is not a social problem and it's more of a medical one, and that this is a chronic disease that people are dealing with. And that's because we've really come to understand the neuroanatomy of addiction much better. that it's an interplay of those dopamine reward pathways in the brain between the amygdala, which is our fear center of the brain, where, that's where the patient or the addicted individual is afraid that they're going to go into withdrawal, so thus they use again to prevent those withdrawal symptoms. And they're not really using to get high at certain points anymore. They just want to use to feel normal. That's because those substances hijack those reward pathways in the brain, and it's so much more overwhelming of a hijacking of that system that they just cannot stop themselves. And classic studies done in the 60s about rats preferentially using cocaine over eating, and that they would essentially starve themselves to death because they were constantly trying to fuel that dopamine reward system, and food wouldn't give that to them. And then that balance of the prefrontal cortex, that's an inhibitory part of the brain that says, I know this is a bad idea. And every person that has a substance use disorder has said that. It's like, I know I'm harming my family. I know I shouldn't be doing this, but I can't stop myself. And anyone in the world of addiction treatment has heard that over and over and over again. And that's really because of the chemical basis of what's happened in the brain. And to boil it down and make it simple, for most people, because I know obviously there's degrees of people's knowledge in terms of what they want to know for neuroanatomy of the brain, but the drug use stimulates the dopamine reward pathways, which is that balance of the nucleus accumbens and the ventral tegmental area, which leads to reinforcement over time. And the more you use that drug, the more it reinforces that behavior, which then leads to craving. When you don't have that drug, you want it, and we're all guilty of this in microscopic levels, where it's like, hey, I did something good. I'm going to go out to dinner and celebrate that. And that's part of that reinforcement that every time we do something good, we want to do this. Or even in the world of medicine, it's like, I got a 96. I want to get 100% on my test. Like we kind of keep chasing that kind of thing. But those are positive reinforcers rather than negative reinforcers. And right drug use is a negative reinforcement that leads to negative behaviors over time. And the more we use it leads to tolerance, meaning I have to use higher and higher amounts to get the same effect, which then leads to dependence, that if I get rid of the drug, I go into a withdrawal symptom. But that is clearly distinguished from addiction, right? Addiction is that you're going outside of societal norms to obtain said substance. And that leads to all the negative consequences that we see, where people have blown their veins and lead to skin popping, or the secondary complications that have just eaten through soft tissue and lead to terrible infections. Or this was a classic photo from Ohio in 2015 or 2016 where a pair of grandparents had overdosed on heroin with their grandchild strapped in the back seat, and a police officer snapped this photo and rescued them with naloxone, and it just leads to negative consequences. So that's what we see when we define addiction, right? And this is taken straight from the American Society of Addiction Medicine. That's a treatable chronic medical disease involving complex interactions among the brain surface, genetics, environments. But what we take from that is it's a chronic disease that has relapsing and remitting events. And what do we see when people have chronic diseases that have relapsing and remitting events, like CHF or heart disease or cancer even? Unfortunately, the revolving door of medicine, it has that filter back down to the emergency department, where we have an opportunity to intervene in that disease and that disease state that's there. And what we've seen is that that classic detox and discharge does not work, right? Like, hey, we're going to get you sober and you're going to live a clean life after that, and out you go. And then the treatment duration, 1, 2, 3 months for a lot of people. And, the recidivism rates are 80 to 90%, where people are extremely likely to relapse. But we're able to maintain them. We can have treatment duration that's engaged and ongoing, which give people back years of their life. And anything we can extend years is what our goal is, And we talk about cancer treatment, we think about 95% 5-year survival rates is the way in which we think about it. Instead of thinking, like, we don't use the word cure, we use the word remission, right? Which is the better way of thinking about a chronic relapsing disease. So what we kind of see and alluded to earlier is that vicious cycle, right? People are stigmatized, they feel shamed, they're self-medicating, they use drugs, and the cycle just keeps repeating and repeating and repeating. So we have to find a way to break that cycle. And luckily, there's a very elegant way we can break that cycle, and that's buprenorphine. It's a partial opioid agonist, so it has low potency but a high affinity at the opioid receptor. So what we see is that it really has a ceiling effect in terms of the way in which the drug works. So when you think about your full opioid agonist, that's your heroin, your hydrocodone, your oxymorphone, these really can be maxed out 90 to 100%, which is where we get all the side effects of our opioids, the respiratory depression, you see the overdoses. But buprenorphine only activates that opioid receptor about 50% in terms of its secondary effects. Again, the respiratory depression is the major one for where we get overdoses. But its analgesic effect doesn't really have that ceiling. So buprenorphine's been around for 50 years, and you can write for it as an analgesic without having to go through waiver training. But if you want to write for it for opioid use disorder maintenance, you have to take a class for it, an 8-hour course in order to prescribe for it. But this drug really has this elegant effect for lower risk for side effects because of this ceiling effect and its potency there. But it also has that high affinity for the opioid receptor, meaning that it will bind the opioid receptor 40-ish times more potent than a lot of your other full opioid agonists. So if the person had just overdosed on heroin, theoretically, you can give them buprenorphine and knock off their heroin. And that, though, is what we might call precipitated withdrawal, where you take them from this effect where they're at and lower them, where they have some withdrawal symptoms. But it will displace that heroin, but you potentially can pull them out of that withdrawal if you just have buprenorphine alone and didn't have naloxone, which is all the way down here. It has no opioid analgesic effect, but occupies that receptor. And here's how it works actually at the receptor level. And now I'm a toxicologist. I love looking at stuff like this. I know many people don't, but this is like how I understand, like when I picture giving a drug, I see this happening in the body. So it's quite much the nerd aspect of what I do as a job, but I love it. So buprenorphine kind of blocks those full agonists, has a partial agonism effect. So that's where you get your analgesia, but it reduces opioid dependence that is there. So buprenorphine actually can be used to slightly wean people down or lower the opioid risks over time, but you want to balance that with maintaining their opioid use disorder as well. But I've used it for opioid-dependent people that were dependent on opioids from their cancer treatment and wanted to get off and didn't have opioid use disorder. And it's very nice and elegant to get them down over time. And then it has its reduced tolerance. And one of the nice things, it has a kappa receptor antagonist effect, which actually plays into depression symptoms. And so actually buprenorphine is used as potential depression treatment. So it actually helps people with co-occurring diseases when they have their substance use disorder and depression. And it's like a lot of chicken or egg, what came first, depression or their substance use. But it works really well to kind of stabilize even their depression symptoms because of that kappa agonist effect. That's all the time I'll spend at the receptor level for you. But the goal is obviously increased retention and treatment, decreasing a lot of our illicit opioid use, decreasing the secondary complications like hepatitis, HIV, reducing incarceration and the burden on our legal system, increasing employment, getting these people back to the workforce, right, and back to the economy, and of course, the increasing survival. So one of the quotes I love, though, is not everything that can be counted counts, because these are the things that will count all the time in terms of our statistics, but not everything that counts can be counted. There's so many little nuances to getting people stabilized on these medications and back with family members, like that father or mother is there for their child and able to help raise them, and how that stabilizes in terms of the trickle-down effect of the family dynamics and what that means for that child growing up to have their parent or their loved one back in their lives, or a brother and sister back in their lives, and how it stabilizes the family and how that perpetuates in society over time in terms of the long term. And obviously that's impossible to measure, but we know it's super important to have your loved one back in your life. And like Howard alluded to this earlier as well too, each time the person presents with an overdose, it is an opportunity for us. And what we have just seen is that each overdose, that person is essentially dead. And the more times the overdose, the higher probability it is that it's going to be a fatal one on the next one. And this study was done that essentially just confirmed that. After one non-fatal overdose, right here, kind of low mortality outcomes, but each time you increase, and this is presenting to the emergency department, each time they have another overdose, this is after 4 overdoses, their statistical probability just skyrockets that the next time that they're going to be found dead. So this is really where our opportunity lies when they come to the emergency department after that overdose in order to get them some treatment. So this was a landmark study by Gail D'Onofrio, ER physician. This is like groundbreaking. This is from about 4 or 5 years ago. Well, what if we start buprenorphine out of the ER? Like, what are our success rates and our treatment rates? And what they found, like the old school way of doing a referral to treatment, here's your paper, here's a list of numbers to call, that only about a third of people would actually call. If you provided the classic, what we thought of for 30, 40 years, SBIRT, like screening, brief intervention, referral to treatment, only about 45% of people, so just a little bit better than that third, actually got into treatment. But if you gave them buprenorphine out of the ER, that 4 out of 5 people, or 80% of people, would actually be in addiction treatment at 30 days, which is just an astounding number to see, that the way, and it broke that stigma that the way we were doing things was the right way, and said there's a better way out there. So we kind of look at it, there's been other studies that we didn't quite have the same outcome, but for the ER doctors, ER providers out there, this one started some ER treatment out of the, or buprenorphine out of the ER, and found about 50% of people were actually treated in 30 days, but one of the nice things they showed was there a 40% reduction in ER length of stay, which to any of our administrators out there, we know length of stay and throughput and turnover times is a big deal, and if you can decrease any length of stay by 40%, it's something you want to do. And for a lot of ER physicians too, what we used to treat opioid withdrawal was, here's your benzos, here's your clonidine, here's some Zofran for your nausea, and people would be in your ER for hours trying to get some of their withdrawal symptoms under control. But if you start them on buprenorphine, a lot of people are better in 1 to 2 hours, like very quickly, and their withdrawal symptoms are stabilized exceedingly fast. And then that can improve your door to disposition times that were measured by, unfortunately. And what we've seen, though, as providers and ER providers started providing this out of their ER, like initially their acceptance rate was really low down here for people starting to do it. Maybe only like, a couple of months that they would actually start. But as time went on, in 6 months to a year, all of a sudden, people start getting very comfortable with it and seeing the benefits in terms of their throughput times. And the number of inductions per month was just escalating and escalating and escalating. So anything that you're looking for short-sighted goals, right? We can't have that viewpoint. We have to think about this as a long-term public health goal that we're looking at. And that we got to move a needle over the course of years, even a decade or two. Like we dug ourselves into this hole over 20 years. It's going to take a decade or two to pull out of it, so to speak, to really get these numbers and stabilize this effect. But as time goes on, we have buy-in. And then so much so that so many different organizations have essentially made it like the standard of care. So this is American College of Medical Toxicology. I know Howard had referred to earlier, American College of Emergency Physicians as well too. But just going to read their line, almost line for line. The ER, or the ED, sees a large number of patients presenting with opioid overdose, opioid withdrawal, or opioid use disorder. And for many patients at high-risk overdose, the ER is their primary access point to healthcare and treatment. Things we know, right? The evaluation ER is an opportunity to engage patients in discussion of opioid agonist treatment and harm reduction strategies to mitigate that risk. And following the initiation of buprenorphine ER, a bridge clinic or warm handoff to treatment provider will improve engagement and long-term treatment. And that is considered essentially the standard of care by many of our societies. And it is what we should be doing. And as we're talking about the standard of care as well too, that provide those kind of opportunities in the future where it's like, if we're not doing this, we're not practicing the standard of care, and that potentially will be at risk. When we're thinking about organizations and business structures, be at risk for opening ourselves up to future lawsuits, litigations, whatever might be there. And that's when you think about the business standpoint of things. But the right thing to do is to get the buprenorphine in the ER. And then, again, from the healthcare administrator standpoint, is it cost effective or not? So there have been plenty of studies on this that, well, hey, if we do the brief intervention or referral to treatment, patients' willingness to pay drops down significantly. But if we start buprenorphine in the ER, their willingness to pay exceedingly goes up, that they're more likely to come back, that they're going to likely pay for that treatment ongoing. So costs a little money in the beginning to make money in the end, right? Those are the classic analogy in the world of business. You got to put some money up front to get the money later, right? So we know that true, and this is just doing the right thing, and we know over time it will lead to that cost effectiveness. And how much? Well, this, I know it's kind of, you can blow it up on your screen to see some of the cost differences, but for people that actually started on buprenorphine in the ER, they had lower overall healthcare costs, that you were saving on average $150 per patient versus not treating them as a whole. So it was more cost effective to treat those patients when you average it out over time and start buprenorphine for them. And then when we look at integrating this into our primary care and inpatient treatment models as well too, if we started buprenorphine for them, patients were less likely to occupy inpatient beds in the hospital, as well as the number of ER visits per month dropped. Again, these are all metrics that people are looking for over time, like how do we get more hospital beds available that decreases ER waiting time, which improves the ER throughput times, and we have more hospital beds available to treat other people. So we know that initiating buprenorphine out of the ER actually improves a lot of these metrics that are there. And to see it on a little bit bigger scale, Vermont was kind of one of the leaders in this. I know Barb's on the line and is able to potentially provide some input into this a little bit later. But the impact of medication-assisted treatment on opioid addiction, Medicaid expenditures, and healthcare services utilization in Vermont. These started this program back in like 2012, 2013, where they really started building out a hub and spoke model. And what they really were looking at was kind of like, what's some of this cost effectiveness? And again, we show that even at a statewide level, implementing a hub and spoke, it was more cost effective to get people into treatment than it was to keep doing the same old, same old. So much so that we alluded to the number needed to treat earlier. The number needed to treat for buprenorphine is 2 to 4 patients. Let's say that again, 2 to 4 for retention and treatment. And there are no mortality outcomes while people are in treatment. In the world of medicine, there's nothing more powerful than that. And let me put this in perspective. We think we got to take our blood pressure medications, and it's going to prevent all these other issues like heart attacks and strokes. The number needed to treat with blood pressure medicine to prevent one stroke is 67. We have to treat 67 people to prevent one stroke. To prevent one heart attack, we have to treat 100 people to prevent a heart attack. For opioid use disorder and buprenorphine, we have to treat 2 to 4 for mortality outcomes. We will never find any better mortality outcomes than that in the world of medicine. It is one of the most powerful drugs we can give. I think I also saw we had some orthopedic people like on the line too. For orthopedics, let's think about an open bone fracture, and we got to give antibiotics to that person. Well, the number needed to treat to prevent a bone infection by giving antibiotics for an open infection is 16. We have to treat 16 people with antibiotics to prevent one case of osteomyelitis. It's just staggering the number needed to treat, or like aspirin for stroke prevention. Like after a person has a stroke, to prevent a second stroke, everyone's got to be on their aspirin, right? We have to treat 140 patients to prevent a secondary stroke that's out there. So it is one of the biggest number needed to treat we actually have in the world of medicine. And then a lot of people will say, well, how does that compare to methadone? Methadone's been our gold standard. We've been using that. I'm just showing this sign. There's a dearth of studies that are out there about methadone. And essentially, it's similar in treatment retention days and drug-free days to buprenorphine. The only differences are there are some people that are going to need higher doses because they're overused. And those individuals are better with the methadone because methadone can provide that higher dose because of the ceiling effect of buprenorphine. And some people do work better with that daily structured visit, like they got to check in every day. So that's really where we want to individualize our patient care. So unfortunately, it's not a panacea for everyone, but it is pretty good for a lot of people. Some just basic buprenorphine facts. We need the X waiver for outpatient opioid use disorder management. You don't need the X waiver to use as an inpatient. You can provide this in the emergency department or provide it while the patient is hospitalized. You do not need it for that. So you can administer the drug while the person's in the hospital. So every ER provider everywhere in the country can induce people on buprenorphine in the emergency department. They just cannot write the prescription for that patient to get the buprenorphine from the pharmacy, but it can be given by any provider anywhere in the country as of this moment, anywhere. We don't need the X waiver to write it for pain management. And there's something to note too, there is a 3-day rule, which I know quite a few people on this line are familiar with, where a patient can actually come back like on day 1, like it's meant to be on a Friday, they come to the ER, person doesn't have an X waiver, they get induced on buprenorphine, but they can't get a script, they can go back the next day to the ER, get a dose of buprenorphine and come back the next day while they're trying to get into treatment on Monday. It's an option. Many ERs don't want to have this because you never know like the amount and volume of people that are there. A person's going to get billed for 3 separate ER visits. There's a lot of logistical issues with that, but it is an option that can be utilized. And we're just kind of on that waiver kind of thing. You know, anyone here that doesn't have a waiver, or if you want to take it back to your institutions, through ACEP, American College of Emergency Physicians, we do have a waiver training core, where essentially nationally we've been doing waiver trainings through Zoom meetings, myself and as well as Steve Holtzford, who's a ER doctor out of DuPage County, out of Delnor Hospital, as well as an addiction medicine specialist, and multiple other providers throughout the country have been waivering multiple providers. So I think as of now, we've wavered over 1,500 to 1,700 providers over the past couple of months. In February also, there's a Get Waivered Illinois Day. I think it's February 22nd, if I remember off the top of my head, where we're trying to host a whole thing for the state of Illinois for whoever wants to be wavered to get waivered. You'll get your 4 hours of CME for free as well, too. And then kind of going back, so what are some barriers to getting waivered? You know, that same study that we looked at also looked at some facilitators and barriers to getting an X waiver. And what we found is that, you know, one of the barriers was that we felt that the process was inconvenient. So something we can think about for organizations, well, what are ways we can get some people waivered in our system? Well, like make it less cumbersome for them. They didn't know the process of how to get waivers. They felt the cost was too expensive. I mean, luckily now the past 2 years, the cost has been nothing. It's been free by a lot of grant programs, which is excellent. When I did my waiver training years ago, I paid $400 to get waivered, which was awesome, you know, at the time, but it is what it is. So, but some of the things we can do to potentially make it a little easier on them is like, essentially if we make the waiver training count as one of their shifts, they'll happily do that. Or if we incentivize them, and I know DuPage County was offering incentive through the end of the year to get their waivers, which is great. Like you get your CME, you check off your state requirement, and you get paid to do this, and it's the right thing, and it's going to help mortality outcomes. It's all win-win-wins, right? So, and then what do you do once you get them on treatment? Well, then there's some of those addiction levels of addiction care that we got to figure out what's the best place for them to go. Well, like level 1s are standard outpatient treatment that we have. They're there. Then we got our partial hospitalization programs or intensive outpatient treatment. We got our classic level 3, which is that kind of rehab 30-day inpatient facilities, or level 4. I mean, this person's so bad they've got to come into the hospital to stabilize them for a few days. So that becomes an issue for a lot of ER providers. Well, where's the best place to send this person? Who's going to figure these little subtleties out of where this person needs to go? I don't have the time in the ER. I'm getting 3 patients an hour. I've got 10 minutes per patient between my ER documentation, my talking to the patient. I've got 5 to 10 minutes in the room with each patient, and that's literally it. You know, because people don't stop coming, and you're going to get pulled out of a room to go see a stroke eval, or a person with a STEMI comes in, or you know, it's just kind of the nature of emergency medicine. So that really comes into play where when we're talking about building out an infrastructure of how do we develop that hub and spoke model, which is a nice system of referral for people that, you know, if you're not sure, you can always refer people up that hub and spoke. So it's coordinated between the primary care, the ER, the hospital, and treatment facilities. It's designed to try and help lessen gaps that are there. So if somebody doesn't know where to do, they can always send them up to the hub, where then they can coordinate a lot of those resources for people. So this is the ideal. This is where we want to get our regions and our state to be. And we're trying to build a lot of that out and trying to coordinate those resources. But, you know, it does take time to coordinate those infrastructure and resources, and that's not where we want currently. But I can tell you from the state standpoint, this is where they are trying to go. And this is all, again, based off of Vermont. So if anyone wants to look a little bit more into that, the Blueprint for Health out of Vermont. And different structure in Vermont's a smaller state than Illinois. They made sure all these services were paid through Medicaid. The hub were billing a monthly bundled rate, and they made sure they distribute funds to the spokes. So the state provided oversight for this. Obviously, again, a different infrastructure. When we kind of look at Vermont and DuPage County, almost kind of mirrored, like about the same size population. versus the state, much different. We have got more insurance companies than Vermont does, a lot of different paid structures and mix. So it's hard sometimes to lay out for a larger state, but this is kind of considered the gold standard. And we'll kind of look at that if once it's implemented. They saw a 96% reduction in opioid use. Like, that's astounding. 89% decrease in ER visits, a 92% decrease in injection drug use, and a $6.7 million decrease in healthcare expenditures. The right thing got people treatment and saved money. And over time, again, as we laid it out starting in 2013, that the amount of referrals just grew and grew and grew. That people saw that this got outcomes. It got results. It did what they wanted to do in medicine and got people into treatment. So it gained more adoption over time. You know, so we have to have that long-term viewpoint in terms of where we're going with this. And when we build it out, knowing that right away it's not going to take off, that you're going to see the improvements over the course of years. Massachusetts as a state also provided some guidelines for developing MAT, and they have a law in place, Chapter 2.8, that requires acute care hospitals that have ED services to have the capability to initiate buprenorphine and to connect them to treatment after discharge. So if we don't do it on our own, potentially there could be legislation that does it. I'm not saying there will be, but that is always a tool that, that can be there. So ideally what we do want is that warm handoff, because we know that this improves their engagements. And this is where we talk about recovery coaches. A lot of these individuals have lived experiences, and they can actually help monitor people through their progress, get them to their treatment places, like drive them to the facilities, talk to them on the phone, coach them through their issues. And yes, when a person who has an addiction issue is in the midst of withdrawal or at the lowest of the lows, so to speak, they don't see the light at the end of the tunnel. But when they see another person that has come through to the other side, so to speak, and is doing things to help other people, it does give them that sense of hope that, hey, this person did it, I can do it, and this person knows what I'm going through, and they can help walk me through this, what I'm feeling, and these cravings, and what I'm experiencing with. And it really does provide that level of security for the patient, where it makes the ER a more welcoming place, and that these individuals are available for these people with substance use disorder. So when we actually look at those kind of outcomes, there's multiple places throughout the country that have instituted these, and these are some of the ones that highlight: the Opioid Overdose Recovery Program out of New Jersey, the Georgia Council on Substance Abuse, Project Point out of Indiana, Cook County Health in Chicago, and I think maybe Brittany Merriweather's on the call today as well too. The services are just absolutely amazing at county, and it just helps dramatically in terms of getting people linkage. But so Anchor Recovery had looked at their recovery support services as well too, and found that 83% of those people that were linked into the recovery coach engaged in recovery supports after discharge from the ER. Again, 83%, 4 out of 5 people. And that only about 5% of people were seen in the ER multiple times. So reduce those ER visits again and again. So we know the reduced hospital readmissions, they have longer sobriety or days of decreased substance use, which again leads to harm reduction. So if you think about it, even like cancer treatment or cancer care, we can provide people more time, right? Because it's not necessarily about the quantity of life, it's also about the quality of life too. We can provide people more time with good days with their families. That's that quality of life that we really are looking for in medicine, to give people lives. It also increased housing stability and improved mental health functioning for people. So obviously when we think about implementing recovery services though, they have to integrate in the workflow, be automated, rapid and flexible referral system, have to comply with CFR 42 Part 2, and get you in quickly to treatment facilities. So the nice part is the ER provider is like, look, I don't have to worry about coordinating all these resources. I can call my recovery specialist. They can coordinate all this for me. And literally, I make one phone call, and then they come back to me afterwards and say, hey, we got him in, or I'm going to drive him over to this place. All I need from you is a 2-day supply of buprenorphine. It looks like they're stable at 12 right now. Can you write that? It's like, sure. And I know they're getting into treatment, and I know it has such a good positive reinforcement. Because again, like we alluded to, the emergency department, is not a good experience. It's every patient's worst day. Oh, hands down, no one wants to be in the ER. So the ER providers are just hit with negative reinforcement after negative reinforcement, and you rarely get that positive reinforcement of this person got better or this person went home. You just get negative. So you get ER providers get jaded because they never get those positive outcomes. They never see somebody look completely different 2 weeks later after you've been stabilized or off heroin. So it's really kind of a nice positive reinforcer to see all these things and know the person's getting the help they need. Other kind of things that are out there to kind of link people, that there are MAT cash clinics. One of the constraints with this is that you can Google it, find a bunch of them in regions. A person has to pay for each visit. It's often like $200 to $500 initial visit, and then $200 each subsequent visit. And they won't bill insurance at all, so they just take whoever's there. So that can be constraining. We view it as like, okay, you know, if they're spending all this money on heroin, instead of divert that, it comes here and we stabilize them. It treats their addiction, but it can be financially constraining for people. There's also MAT bridge clinics. So if there's linkages from hospital systems to a bridge clinic, they can say, look, here's your 3 days. You're going to get into the bridge clinic on Monday. Here's your dose of medication for these 3 days. You got an appointment Monday at 8 a.m. So then at the bridge clinic, they'll help kind of coordinate, where does this person need to go? What level of service do they need? And write them the prescriptions and follow them over the course of a week or two until they get into if they need a long-term support or long-term recovery housing that are there. Ideally, though, people should be seen about 1 to 2 days in these bridge clinics. So with some hospital systems, like for instance at County, we do have a bridge clinic that even has walk-ins available during the week, where we know as ER providers, look, if we can't get them in, they're not going to go to a treatment facility, we can get them into the bridge clinic early next week. We know treatment in prisons also works, you know, over and over as we give them buprenorphine and naloxone as well, because it's another entry point for a lot of people. Their substance use has led to interactions with law enforcement, and a lot of people wind up in prisons. And as we know, when people are discharged from prisons, they try to go back to using the same amount they were using before, but if we initiate them on buprenorphine prior to the discharge from prison, they're less likely to overdose. There's telemedicine as an option as well. And one of the benefits of COVID was that there were some waivers that were put in hold. So one was the change to the Ryan-Haight Act, Consumer Protection Act, where to write for a controlled substance, you had to see a person physically in person. Now with this, the DEA will allow for buprenorphine induction just via phone. You only have to do a televisit. So you can call one of your providers and you can talk to the patient over the phone and like call on a prescription of buprenorphine to them for their pharmacy. And that was kind of one of the nice things of COVID. Now, how long this provision will remain in place is yet to remain seen, but it is an option for us now to increase that access. Also of note for the legislation standpoint is the POWER Act, so it's the Preventing Overdose as well, and the Emergency Room Act. This is a grant program that's established if people are looking to kind of take advantage of. It's kind of like the 340B programs and everything else, but it's a grant program that's out there as it's specifically designed for people that want to develop programs for discharging patients after they come in with a drug overdose, and all meant to enhance integration of post-discharge care for patients with substance use disorder. Other kind of things on the horizon was the easy MAT for opioid addiction, meaning that, you know, we had that 3-day rule before where a person has to come back. Well, this is on the docket right now that the ER potentially will be allowed to dispense a 3-day supply of buprenorphine to the patient, kind of like, you know, our sexual assault medications, everything else, instead of having the person come back each day and instead of writing a prescription for them, that they can actually give them 3 days worth of Suboxone. There's also the Mainstream Addiction Treatment Act that is currently in Congress, but essentially that is the X waiver is what it is trying to get rid of the X waiver altogether, because it is, from a physician standpoint, kind of ridiculous that we have to take an 8-hour course to write for one medication for this indication. It also contributes to the stigma of opioid use disorder and the stigma of buprenorphine as a whole. When we can prescribe buprenorphine for pain management, but we can't prescribe it for stabilizing somebody with opioid use disorder until we take this 8-hour course. We don't have to do that for any other drugs that are out there. Also in 2021, for people to know, Medicare will start reimbursing, Medicare, Medicaid will start reimbursing for MAT out of the ER. So what we wind up seeing is that our entire world is interconnected. And the ER itself is that central kind of focus, and often it is difficult to see the forest through the trees, so to speak, where you're just getting hit over and over and over again with multiple cases, so you don't get the big picture. And it can be a very congested, crowded place. If we want to make things work out of the ER, we really need to make it smooth and seamless because people are pulled in so many different directions. So in summary, our starting point is we try to get every entry point. Every ER provider should have the X waiver. And ideally, every primary care provider and kind of frontline access person like OB-GYN doctors, as well as where people initially meet the medical system, should have the ability to write for buprenorphine, so that way they can at least stabilize some of their individuals to get them into treatment. Because without that, they're only going to use heroin or any other opioid very shortly, and their risk for death just skyrockets. We need to make that workflow easy out of the ER, make our EMR systems work for the providers rather than make the providers work for the EMR for billing and documentation. Recovery coaches and establishing that warm handoff is a great way to do that, but we need those MAT clinics to be available. And we got to create that referral system. So whatever our hospital is or our hospital location is, start creating those linkages in the community wherever it is, and let that linkage be known. Like, we know that if we don't have a neurosurgeon at our hospital, that I'm going to send them to Northwestern because they have neurosurgeons there, and I got that linkage in place, and that's my first call every time. So we know that. So for addiction treatment, we should have that there. Obviously, the Illinois Helpline potentially can help provide a lot of those, and I've been trying to make it known to as many people, like, hey, it's here. Like for the Poison Center, there's a ton of refrigerator stickers that are out there in the world. Helpline, we want to do that as well too, right? So thank you. Willing to take any questions and stuff right now. I know a lot of information in a short time period.
Dr. Nelson, we do have some questions. I know we wanted to try and have a little active discussion too. So
yeah.
Lots of support to the X waiver. One of the questions was, are physicians in favor of that? It sounds like your thoughts are yes, and you're getting lots of support in the public chat to make those changes too. And then there were questions about existing linkage to individuals in treatment deserts and long waits at clinics. Wait lists are not uncommon, so even if it isn't a desert, there's still barriers. Any comments on that?
Yeah, it's difficult in a lot of our MAT deserts because, again, some of those logistic barriers and patient transportation barriers, and potentially there's only one or two providers. So you can imagine it's like another funnel, right? If there's only one provider in an entire region seeing people and there's a lot of people, the wait list is going to be long. So that is one of the, again, nice benefits of telemedicine, where potentially people can get linked into treatment providers and can have regional providers, even like multi-state providers, like a doc out of Wisconsin who is also licensed in Illinois can provide telehealth services to those individuals, or even statewide or nationwide. So I really do encourage a lot of our MAT desert areas to try and hospital systems to look into a lot of the telemedicine issues that are out there and let those resources be known. And there are quite a few, and I never want to kind of report one over the other, because obviously then that creates bias. Well, this is the one I like to use or not. Like, I just let you know there's a lot of options out there.
Thank you. And this next question is related to work as an engagement specialist in a local hospital, understanding that the objective in the ED is to stabilize the patient and discharge or admit them, whichever is appropriate. Do you have any suggestions on how to encourage an ED doc to hold a patient a little longer after being considered stable, so that an advocate or recovery coach, some linkage can be made and a referral? In particular, do you have any suggestions if the patient is unfunded or Medicaid?
Yep. So first, what you do broach on is a very common issue in emergency departments where this has been going on for years. It's what we call ER boarding, and not just for substance use disorder patients, which we're seeing ER boarding in the world of COVID right now, with COVID hospitals just being full too. And unfortunately, without a space to send patients, people don't stop coming into the ER, and this leads to ER wait times as well. So if you don't move a person out of a room to open up that room, your waiting room just grows and grows and grows. So ideally, if a hospital system wants to create an area, so to speak, for holding of these patients, you're going to have acceptance for providers saying, okay, fine, I can open up my treatment area because I'm not providing any more treatment for this person right now, and they're stable and they're just waiting for 3 or 4 hours for a recovery coach to come in. Then, and I'm not holding this bed because I could get another patient in here. And again, that's where you'll see you get patients pulled out and put in a hallway, and then the patient again feels stigmatized and ostracized, like they're just leaving me in the hallway and people are just walking by me all the time. And these are all discussions just for overall hospital system flow. And every ER provider across the country wants ER boarding gone because it only leads to decreased health access. So ideally in a hospital system, if you have a treatment or holding area where you can have a person sit that's not in that treatment area that the provider is managing where they can improve their weight flow, they're going to have acceptance because it's like, look, I'm moving this person over here, they're going to get their treatment, and I'm opening up a bed, which improves the throughput times and makes sure that the person in the waiting room isn't dying. Then, of course, you're going to get that. Without that, though, unfortunately, there's not a great solution for that. So this is where you really need our hospital administrators and the C-suite champions to come up with innovative strategies and locations for those specific holding areas or for borders, so to speak, which can be easily done, but we need the buy-in from that. But then I get it, too, because it's money, because then you have to have somebody watching these people and nurse watching them because they're still on your board in your ER, and that's, you have to pay somebody to do that. So that has been a logistical era for 20 years that hasn't been fully figured out as a whole. I personally, in a county, we have some space and hallway issues and a few other things that what we call a transitional area, kind of meant for some of that, where we can put some of these people that they are being observed by some of our techs. So if there's an issue, they can come get us. And it's a nice area that we can do that, but we'll still run into those issues despite having that.
This next question is more related to primary care docs or other physicians that prescribe buprenorphine, and they often have competing priorities in their practices. So what we're looking at here is how do we support providers in making more of a commitment to outpatient treatment for OUD, increasing their capacity and such.
Yeah, so that's building out those spokes. And really, I think for the primary care provider and the outpatient clinic doctor, they need to know first and foremost that they have that referral pattern up and where they can send their patients, that they have the support to manage those patients. Because without that, you're not going to have buy-in from them, because there are a lot of time constraints, there are a lot of pressure issues, and to walk somebody who's going through a crisis, and again, you have 15-minute visits for your primary care provider to get 4 patients in an hour, and somebody is relapsing or using heroin, they just don't have the time ability to deal with it. They're more likely to do it when the person's stable and when they're having issues, like, hey, I know you're having issues today, you're going to go in and see this person at our hub or our regional issue, and we're going to help stabilize you. And when they know they're going to have that support, you're going to get buy-in. Because unfortunately for them, again, it is a volume game in order to meet their RVUs, in order to meet their logistical business end of running a practice, which is the business of medicine. So if the system itself is built and the infrastructure in a healthcare system is built to provide that support for them, or regional support where even if the healthcare system doesn't have it and that provider knows they can send them somewhere else that's going to get that and that linkage is there, you're going to see the buy-in because you're going to have mortality improvements. It's like any other disease. If you see improvement in health, it provides that positive reinforcement.
Dr. Nelson, when you see,
unfortunately.
Thank you. When you see a patient with a substance use disorder, an opioid use disorder, and they have children, do you find that as a mandated reporter you have to report that?
No. It's not that it's a tricky situation, right? Because are they specifically putting their child in danger or not? And think about how many overdoses that you see. Are you asking them, okay, what age child do you have at home or not in the ER? Like, it's never been kind of the standard of care, so to speak. Now, if you directly have witnessed that their substance use has placed the child at risk, like the child has gotten into their substances and overdose, of course, that's a hands down yes, but for instance, like if this person's using, you don't know the logistics of their substance use, you don't know the family dynamics, you don't know any of that background, are they using marijuana? Does that qualify? And now that marijuana is legal in the state, it's a slippery slope. Okay, do they drink alcohol? Does that qualify? Where's the line? Are they smoking in the house? Is it secondhand smoke? So substance use itself has never been thought of as being at risk to the child unless the child is directly endangered by the substance use, which I know we can talk, there's indirect things, okay, if they're passed out of their heroin and they're not watching their child and their child puts their hand in a blender, I get all that, but like where's the line and at what substances? Because we know all those substances have secondary health effects on children and in the household. And you can say the same thing too with prescription drugs, like, hey, if grandma spills a few pills on the ground accidentally and just can't see them because her eyesight's poor and the 2-year-old toddler comes over that's visiting and gets into a pill, do you have to mandate grandma because she didn't take care of her prescription drugs, right? So it's never been the standard for an individual substance use unless you have direct evidence it is affecting the child.
Okay, we have about 3 minutes. The last, just to wrap up the conversation on ex-waiver resources, if someone's looking for incentives or a program or organization that's offering incentives for waiver training, we would refer them back to Super probably, and I know there are some local ones, but would you start with Super then?
Yes, great resource. They are fantastic, everyone over at Super. And I would definitely start with them and check out their website. Regionally, Google is great, like the Google Assistant, like, hey, just type in regional resources for waiver training, DuPage County, and you're going to hit those links as well too, or like type in for waiver training in your region. If there's regional or even national, like PCSS was offering a national one for a short time period. And that's, if you just signed up for anything, like you would anywhere in the nation, you could get their grant waiver. So they kind of come rolling along. So definitely just Google is an easy resource and everyone has access to that. But Super is a great resource for our local and state.
Okay, we have about 1.5 minutes. I know, Dr. Nelson, you had a couple of discussion points, but since we're at our last 1.5 minutes here, does anyone else have any questions they want to put into the all questions chat, or, Dr. Nelson certainly jump in and offer some summarizing comments. Okay, we do have one more question on, you see it?
No, which one? Sorry.
It's the recommendations on using buprenorphine for pain management. Do you have any recommendations on that?
Oh yeah, actually, there have been a lot of recommendations that we potentially should be using buprenorphine more than our other full opioid agonists, like Norco and hydromorphone or oxymorphone, because of its safety profile. And obviously, as you increase prescribing of one drug, you are going to see the secondary consequences of such. Like the more buprenorphine that we have out there, the more likely there are likely to be incidental accidental exposures by toddlers or kids, et cetera. And there are data to support that as well too, but it is safer than your other full opioid agonists and just as effective for pain management. So we've done studies on kidney stones, long bone fractures for that. So, but it's hard to change systematic practices. From whenever evidence comes out in medicine to widespread adoption is about 10 years for that, because you have to have an entire generation of doctors that have had this training kind of come in to move that needle. You need about 10 years. So you have to have the old dogs that have been practicing for forever to start retiring, and then the new grads come in and need about a third to 50% of those people that have that training before the practice of medicine really changes, which is even like you're talking about COVID, like we need 60, 70% of people to have immunity to start seeing numbers go down. Like, so you got to see that turnover, that roll up. So for that, yes, I've written buprenorphine for pain? Absolutely. Do I give it for some people in the ER for pain management? Yes, I do. And do other people give it? Absolutely. Like our pain management docs give it. but it's not the common practice. A lot of people are just comfortable writing for the hydrocodone or the whatever they've been writing for 10 years, 20 years, because they're comfortable with it.
Hey, Dr. Nelson, where are they in that 10-year adoption time frame to writing for more buprenorphine for pain management?
Actually, we're at the beginning of it. Now medical schools, starting around 2016, 2017, have started talking about addiction treatment, a lot of other things. So now we're just starting to get med school grads coming out that are literally asking about this. This never happened before, asking about these kind of things and harm reduction strategies. So we need to have them go through training, but we are at the beginning end of that from, the national opioid epidemic news in 2017. So, we're in those first few years of that cycle, unfortunately. So to really see why this is a long-term game, where we're looking at this 2030, 2040 for long-term total public health, like improvement as a whole. And you'll look back 20 years from now and be like, okay, here's our peak. Here's where we started coming down, and we'll see this trend. Obviously, we want to move that needle faster if we can, but it's getting there, and we are making headway. Like at county, for instance, now 60 to 70% of our ER doctors are X-waiver trained, with the goal actually by February, almost 100% of us will all be X-waiver trained, as we have a few more things, and trying to do more for the city and surrounding Cali regions as well too. And the more we do, the more education you provide, the more you show numbers and statistics, and the more they have the positive reinforcement of implementing into their practice, the more likely it's going to become widespread.
Well, unfortunately, that does up all the rest of the time that we have today. We lost Mila's audio, so I'm going to jump in here and wrap up. We're going to leave the room open so that you can continue to download materials. If you have a couple of questions that you want to put into the public chat about how to download materials or anything else today, go ahead and use that chat. We'll leave it open. But we will be closing out the audio and the video now, and we'll end our recording. So thank you all so much for coming out today. It was a very engaging session. We certainly appreciate your time. And again, if you have any questions, do let us know in that public chat. We'll leave the room open for probably about 5 more minutes. Thank you so much, and have a wonderful day.
Thank you so much. I do appreciate it.